Hello, hello, hello. Hello, my friends. Hello there. Hi, my name is Jill Osborne. I am the president of the Interstitial Cystitis Network. How is that for a mouthful? Man, if I only had $1 for every time I've had to say interstitial cystitis, I would be a wealthy woman at this point in time. It is Sunday, September 3rd. It is time for a support group meeting. I'm very happy that I can actually do a support group meeting right now because we are in California and we have been dealing with massive fires. And I could not stream last weekend. Then they turned our power off. And I don't know if you can see the shirt I'm wearing, but this is actually an olive green shirt, but it is turned orange because of the orange in the smoke outside. How is that for crazy? All right, the purpose, I'm just trying to set my computer up here. Hold on a sec. If I'm looking a little worn and torn, you know why. It is fire season. It is hard for us. All right, my purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you again. I don't want anybody to be able to minimize you or demean you or tell you that IC is all in your head or tell you that there's no treatment or tell you that this is incurable when in fact some of these subtypes are indeed curable. My job here is to educate you, to inform you, to increase your knowledge level so that we can get you back into the doctor so that you can have better discussions about your treatment options so that we can understand the landscape of your pelvis and try to figure out what the hell is driving your symptoms. It is very, very important that you understand that sometimes it's not the bladder, even though you're having frequency, urgency, pressure, pain. Doesn't necessarily mean it's coming from your bladder. It could be coming from something else in your pelvis. It could be coming from a fibroid tumor pressing on your bladder. It could be coming from endometriosis. It could be coming from pelvic congestion syndrome. It could be coming from a Tarlov cyst. It could be coming from a chronic fungal infection. Thank you, Andrea. Hello, Donna. It's nice to see you. I miss you guys. Hello, Amber. Hi, Brenda. Hi, Rocio. Hi, Carolyn. Elena says, how are the fires? The fires are terrible. Worst year yet. We've lost. Listen, fire season hasn't even begun. It normally doesn't begin until October. We've lost 3 million acres so far, probably more, probably 3.5 million as after yesterday. The smoke is surreal. If you saw those pictures of the red skies and the orange skies, that was us all day. It was like living on Mars. And the smoke has been so intense. Like, I wish you could see. I can kind of see the hillside outside. They say that the winds are supposed to turn on Tuesday. So right now, the smoke that we're getting is coming from the south. It's coming from big fires down in kind of central California, maybe about 300 miles away. The nearest fire to us, the reason why we were evacuated, is out. That was a 70,000 acre fire up west of Healdsburg. So we're here, but if you see wrinkles on my face, that is why. I was talking to my mom last night. I was just saying, this is unbelievably difficult because literally on a moment's notice, you have to run. People are dead. You got dozens of people have died. They're expecting mass casualties in Oregon. These fires move so quickly that they move a football field a minute, sometimes 2 football fields a minute, 3 football fields a minute, right? That quickly. And you can't outrun it at some point in time. The embers are about a mile ahead of the fire line. So fire breaks in the forest don't work. And regardless of what a certain person keeps saying about maintenance, right now it's in national forest. So you can't all blame the state of California for this because national forests are burning. Most of the national forests are closed now because of this. So anyway, it is, I'm exhausted. I'm really tired today. And we've got at least 2 months to go. So I'm upset that I can't do anything for IC Awareness Month. You guys, September is IC Awareness Month. Y'all know that. Now, this is the time when we are supposed to unite together and tell our stories about IC. But this year, it's really hard because there's a lot of other things that are going on that are, honestly, to be quite honest, more important than that right now. From COVID to the fires and people, obviously not being able to get away from the fires, to other things. It's an odd, awkward IC Awareness Month this year. I mean, normally we would be in and doing a lot of events, and I just can't schedule events right now because I don't know. Oh, Amber says she's been posting the facts on your Facebook. Thank you. If you go over to icawareness.org, icawareness.org, that's the Awareness Month website, there are daily facts that you can post. There's also a really good press release you can print out and send to your local paper. I couldn't even get the press release out. I'm going to try to do it maybe tomorrow or on Tuesday, try to get it into a national media service to get it out. But, this is a year where we're just going to kind of hang back a little bit. I do want you to know that Rob Moldwin, one of the top IC doctors in the nation, the author of an older book called The Interstitial Cystitis Survival Guide, is going to do a 3-hour pelvic pain seminar over Zoom with the ICA in a couple of weeks, or like I think on the 26th or something like that. And so I would really encourage you to attend that. I think the more we collaborate and work together, the better. This is a great opportunity to see one of the national experts on IC. And when things calm down here, we're going to be able to do more. But it's just been an insane year. Donna says, my contribution is to do something every day, like walking, even when I feel pain, to challenge myself to do better and become stronger. That's wonderful, Donna. I don't know. I don't know what mine is. Mine is, I gotta say, I think my resolution for this week is no gluten and no dairy. And I've already broken that. I've been doing a lot of reading on inflammation and I just wanted to see if I could do it. And I was out in the smoke yesterday, and my throat got really scratchy, so I had to have a little bit of ice cream just to calm my throat last night. Otherwise, hey, we're going to call it the stress 10, the extra 5 or 10 pounds. Hello, Annie. Hi, Carolyn. Hi, Debbie. Hi, Tina. Tina says, hello. Finally, I had DNA testing and found bacteria after 7 months. Tina, what was the bacteria? Hello, Carla from Namibia. Welcome, Carla. It's wonderful to see you. I was just working with somebody in Ghana a couple of days ago. Karen says, is Stanford a resource for treatment? Well, Dr. Chris Payne, who ran the IC research program at Stanford, retired from Stanford a couple of years ago. And so I believe that his patients were being referred to Dr. Phil Hanno, who is the national, how do I want to say this? Phil Hanno is the chairman of the IC committee for the American Urology Association. Phil Hanno is the key representative at the National Institutes of Health. So Phil Hanno is kind of like the government leader, the administrative leader of the entire IC research movement. And he's a lovely man. He's an absolutely lovely man. And he is seeing patients. I don't know what his schedule is, though. I exchange email with him occasionally. So Phil Hanno is at Stanford, and I do believe that Chris Payne's old nurse practitioner might still be at Stanford. So I'd say give it a shot. Listen, guys, you got to understand something that local doctors, especially local urologists, right? They don't necessarily have the time or the money to take the latest class on IC and pelvic pain. They might be treating IC with Elmeron and DMSO out of a textbook. And when they have the opportunity to go to conferences, you got to understand that there's a ton of classes there. The odds of them taking a class on IC are slim to none. They're going to be taking classes on cancer and other stuff like that. And reconstructing the bladder and birth defects and stuff like that. And so you might spend 1 year, 2 years, 5 years, 10 years with a local doctor who's just not getting it. And there comes a time when you deserve to see somebody who's truly knowledgeable and informed about IC, who gets it, who understands, who's up to date on all of the latest research. Dr. Phil Hanno, Dr. Ken Peters, Dr. Robert Evans, Dr. Robert Moldwin, Dr. Denise Pecht are just some of the doctors who we would consider top tier doctors, who we know are fully informed of all of the new things that we know about IC right now. Yeah, so in our magazine, the IC Optimist, I don't have a copy of it. They did not send me, they did not. Oh, did they? Here, hold on. Let me go look at my front doorstep. Hold on. Darn. So our summer, our late, late summer IC Optimist is now done. And you can download it right from your member page right now. It's been up for days. And our print version will be going out this weekend, if not early this week. So in that, I summarize a whole bunch of the new information on IC and all of the new research studies that were presented at the American Urology Association. Couple of highlights from that, just out of curiosity. I mean, if you're curious about kind of what the geeks are doing right now, what the researchers are doing. Number one, pretty much everybody in the world is now agreeing that Hunner's lesions is a separate disease. Why? Because when you biopsy a Hunner's lesion, you find massive inflammation and deterioration of the bladder wall. So what if that maybe 10%, 15% of the overall IC patient community? The rest of us have a pelvic pain syndrome, bladder pain syndrome. And so now they are very clearly separating the two. In fact, I've built a new website, hunnersulcers.org. And I think I have Hunner's lesions too. And we're getting ready to split these so that the Hunner's lesion patients get the attention and the research they deserve, and that they don't get all muddled up with those of us, myself included, who have a normal bladder wall, but we still absolutely have bladder and pelvic pain and bladder symptoms, right? Okay. Let's see, what else happened there? Well, I've got the magazine right here. Hold on. Give me a momento. I don't have I sit in front of two computers here. And believe it or not, I could use a third one. It's ridiculous trying to do all this. All right, hold on a second. There it is. Oh, this is a good issue of the IC Optimist. I am really, really happy with it. All right, so the highlights of the American Urology Association this year. Oh, here it is. Here's the other big thing. How many of you have had a hydrodistension with cystoscopy and they found little red dots on your bladder? You know, I've got a picture of it, right? So like, look, these are Hunner's lesions. This is what a Hunner's lesion looks like. Okay, big red center and little arms that radiate off of it. And again, if you biopsy that, you find massive inflammation, which means there's a war happening right there, that your body's fighting something intensely, along with bladder wall damage. You can actually see the bladder wall breaking down, right? But remember, that's only 15% of you. So how many of you have had this? Petechial hemorrhages. We call these little petechial hemorrhages or little glomulations. Do you think this is IC? It's not. They no longer believe that this means anything, that glomulations are the result of the test, that when you stretch the bladder, this is what happens. And so in the big giant class that Phil Hanno taught, that was one of the points they make is how did he say this here? How did he say this here? Glomulations have very little significance and are most likely a false positive caused by the test itself. Dr. Hanna says patients with glomulations who do not have urinary symptoms do not have interstitial cystitis. How do we know that? How do we know that? Because they tested women who had no bladder symptoms, who were scheduled for a tubal ligation or another procedure, and they gave them the same test. They hydrodistended their bladder, and this happened. And we knew that years ago. We knew that years ago, but now that's becoming more formalized. You'll see now that the finding of glomulations on the bladder are being removed from all the disease definitions. Let's see, what else do we have here? I guess, I didn't even introduce myself. Oh, I'm sorry. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network, longest serving IC support group leader in the United States, 27 years and counting. And I'm the founder and president of the IC Network, rated #1 in the world by Harvard Medical School and the University of London in 2 peer-reviewed research studies. So when you come to our website, icnetwork.org, please know that that both Harvard and the University of London have rated our website the best website on interstitial cystitis for accuracy, credibility, reliability, readability, etc. I'm really super proud of that. All right, let's see, what else do we have here? You don't need to know about that. Okay, here's something interesting. Here's something interesting from AUA. So again, when we talk about our subtypes or our variants of IC, right? Because not everybody's the same. For some people, IC begins in childhood. For others, IC begins after menopause. They're both diagnosed with IC, but is it IC? No. Is it the same? Absolutely not. Some of you have pain. Some of you don't have pain. For some of you, IC began after chemotherapy. For others, IC began after having a baby and a difficult delivery. Both diagnosed with IC. Are you the same? Absolutely not. And so we have been saying for many, many years now that you have to consider the concept of injury. That yes, the bladder can be injured, just like your pelvic floor can be injured. So what normally injures the bladder? Well, chemicals. That would be an example. A chemotherapy. These are the patients whose symptoms begin after chemotherapy. Or if you hold your urine too long. I was working with a lady 2 days ago who held her urine for 12 hours, and her symptoms began immediately after that, right? So in this big class on IC that was taught at the American Urology Association this year, Dr. Lavaz, who's from Europe, shared his theory on why the bladder wall becomes dysfunctional. So he says, #1, a bladder insult occurs. First occurs perhaps from chemotherapy, holding your urine too long, even a UTI. That at some point in time, the tissue of the bladder is damaged. So step #2 is the tissue becomes damaged. At this point, it is, okay, well, that's all I need to say there. So what happens then when you have a damaged bladder wall? Urine leaks into the bladder wall. Now remember, the purpose of the bladder is to hold toxic waste because urine is body waste. Urine contains ammonia and urea and all sorts of other icky stuff. So how does the bladder protect itself? It has a nice, really thick, robust coating of mucus that acts as a barrier, keeps urine there, and it protects the cells, right? But when the bladder wall is damaged, the toxins in urine now seep deeply into the bladder wall where it irritates nerves, causes mast cells to release histamine, etc. So this is what he says here. Urine leaks into the bladder wall, especially the potent irritant potassium, where it triggers a variety of reactions in local tissue. Number 4, in response to that irritation, whoops, hold on. Mast cells become active and they release histamine. This then triggers nerves to release another irritating substance called substance P. And now while this is happening, a progressive injury occurs. This then triggers the pelvic floor muscles to get tight in that viscerosomatic reflex, and it causes an inflammatory reaction in the nerves. Okay, so injury, trauma is something that we are really, really looking at now. Now, of course, for some of you, IC began after a muscle injury. You know, I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? The reality is that they're both involved. They both cannot not both be involved. They are too interconnected. So yeah, for some of you, IC definitely began after a bladder injury, no doubt about it. But for more of you, IC began after a muscle injury. And the muscles are tight, they're restricting blood flow to the bladder, and the bladder cannot be healthy with good blood supply, and then that also causes nerve issues. Let's see here. Carolyn says, had another UTI, so fed up with them. Can I hear a hallelujah? You know, there's absolutely a group of people who do get recurring UTIs, usually related to estrogen atrophy. I attended a really good class years ago taught by Dr. Anthony Schaefer, who talked about that. And what he said is that there, for people, especially women who get recurring infections like every month, every 2 months, they were trying to study that. And so they had patients in a research study and they took daily urine samples and daily vaginal swabs, and they just were studying them. It's like, why is this person really legitimately getting a recurring E. coli infection or whatever? And what they found in that study is that about 24 hours before that bacteria arrives in the bladder, it is actually in the vagina. So that then led the researchers to ask, well, why has the vagina become a safe haven for bacteria? What's happened to the vaginal defenses? And it comes back to estrogen atrophy. That when you are perimenopausal, menopausal, postmenopausal, you don't have a lot of estrogen anymore. Therefore, that nice thick coating that's normally in your bladder is now diminished. And normally in your vagina, it is now diminished. And that makes it easier for bacteria to live and survive and thrive and reach those cells and infect those cells. And so generally for those women, you're going to want to do a product that contains proanthocyanidins, also known as PACs. And that would be, let's see, where is it? Here it is. That would be Prevent or Allura. This would be the product that you would use to perhaps try to make the environment a little bit more hostile to bacteria. Okay. Also, remember, my friends, remember that toilet tissue will not remove bacteria off of your skin. Water will. So everybody who becomes a member of the IC network, you all get water bottles because you're supposed to rinse yourself off and then dry. And so if you're struggling with infections, that's a basic hygiene that you want to do. But I don't want you to think that I'm telling you that your infections are because poor hygiene. That's an old wives' tale. What we're finding is infections are coming from food. E. coli infections are often coming from chicken. Y'all remember the Costco chicken scandal? Yeah, it's coming from food. So don't fall into that old mindset that you're dirty and you've done something wrong. That just is not true. Amanda says, I grew up in California. I lived in Canyon Lake. I remember helicopters getting buckets of water in the backyard. Yeah. Yeah. Hello, Peggy from Kentucky. And then I just saw somebody from England. Hello. I might have been Carolyn from England. Nikki says, I'm in a big back brace for a month. Because you fractured 3 vertebrae. The brace and the fractures are causing a major flare. Thank goodness for Desert Harvest products. Yeah, Yeah, good for you. We do have another aloe product that I quite like that's called Aloe Path. And so Aloe Path has organic anthraquinone-free, anthraquinone-free aloe combined with PEA for a pain reduction effect. So for those of you who like the soothing effect of aloe, just know that the addition of PEA might help take that to the next level in terms of reducing a little bit of pain and discomfort. Let's see. Verna says, if you do not follow the IC diet, will the condition worsen due to the acidic falls? Yeah. I mean, listen, if you've got a bladder wall injury, if you're IC or Hunter's lesion, so you're IC subtype 1 or subtype 2, and you've got an open wound on your bladder, and you keep pouring acid in that wound, absolutely, that wound is going to persist and probably get bigger. You know, I've talked about my story a little bit. Although I had frequency urgency when I was young, I didn't have bladder pain until I was 32 after a swimming pool accident, and I sustained a chemical burn. My first diagnosis was chemical cystitis. And while I would like to think that I'm fairly smart, I did not understand the degree of the injury that I developed. And so what was I doing? I was drinking a massive amount of cranberry juice, a quarter cranberry juice a day, not understanding the toll that that daily acid load would put on the wound in my bladder. And so by the end of that year, I was a wreck. I mean, I was at the emergency room. I did 3 days in a row at the emergency room. My pain was so bad. And I really believe in hindsight that it would not have been as bad if I hadn't been drinking the cranberry juice every day, that I probably would have healed much better. Jessica says, how do we get the print versions? They'll be available in our store. It's already loaded up, ready to go. I just couldn't activate it in our store until they were delivered. And I think they were delivered yesterday. So I will try to turn it on tonight. You can get the email version of our magazine right now. And the print one, I will remember to try to activate tonight. I prepared the listing and everything. It's just turned off. Lina says, I've been going dairy-free and I crave ice cream. I get this. So I get the delicious coconut milk cream. Oh, I do too, hon. I love coconut milk ice cream. Jessica says she finds milk helps you. Yeah, milk, it does not irritate the bladder at all. It does not irritate the bladder at all. But, you know, kind of there's a little bit of a theory here that inflammation is often driven by some of the products in dairy as well as gluten. And so while a gluten-free diet is generally not recommended for IC, I think it's very interesting to try. When I'm generally gluten-free most of the time. I feel much better when I'm gluten-free, even though I tested negative for celiac disease. So I have gluten-free pancake mix and biscuit mix, but I do eat Ezekiel bread. So anyway, you know, we're always playing. Just want to be the healthiest we can be, right? Today's modern diet is not necessarily healthy. Jessica says she's never had a cystoscopy and you're scared to, honey. You mean a plain cysto in the office? I call that a looky-loo. 5 minutes in and out. It's nothing to worry about at all. You know, at some point in time, Jessica, you have to, you know, if you don't let them look in the bladder, you're forcing your doctor to guess. And that doesn't work for very long. If your symptoms are persisting, if your symptoms are getting worse, if you're not responding to therapy, it is time to let somebody look. A plain cystoscopy in the office, it's just they numb your urethra, they stick the cystoscope in, they look, they pull it out, bam, you're done. I've had 2 or 3 of them. If my doctor wanted to do one right now, I would stream it. I honestly, I would. Isn't that an interesting? Maybe I should stream a cystoscopy. Except my bladder's pretty good right now. Okay. So the only issue with a cystoscopy is that it's going to stretch your urethra, and the first couple of times you pee afterwards, it's going to sting because you've just stretched your urethra. The advantage of a cystoscopy is you're allowing them to look fundamentally at your tissue, and that's important. And you don't want to let fear stop you. We want to look. So I've told the story several times of a woman who was afraid to have a cysto for years. Her symptoms kept getting worse and worse and worse and worse and worse. Finally, she was like, all right, look, do it. Look in there. What did they find? A giant bladder stone that was cutting her bladder wall. Kidney stones and bladder stones are giant. They can be giant and they're sharp. They have sharp edges and they're covered with bacteria. And so she clearly, at some point in time, passed a kidney stone. It did not get through. It grew and grew, got bigger and bigger, and was floating in her bladder, cutting her bladder wall for years. And as soon as they broke it up and got it out, what do you think happened? Her bladder healed, her symptoms went away, she was fine. So she suffered for years with something that was completely curable, which was a bladder stone or a kidney stone floating in her bladder. Kim says, hey, Jill, my mom spoke with you in 2011 when my IC was the worst it's ever been. I appreciate your input and advice, and I'm grateful for your advocacy. Kim, it's awesome. Please tell your mom hi for me. It's so fun to find some of my original IC support group members too. I'm still friends with quite a few of them. Lisa says she had waterfall bleeding. So if you have waterfall bleeding in your bladder during a hydrodistension, then you have Hunner's lesions. If you have Hunner's lesions and they do a hydrodistension to take a closer look at your bladder, and if you have profound bleeding, that means you've got Hunner's lesions. It's called a waterfall effect. So let me just compare that. So there's a plain cysto, which I call a looky-loo, and then there's a hydrodistension with cystoscopy. So what's a hydrodistension with cystoscopy? What that allows them to take a closer look at your bladder wall. So what they do, you're always under anesthesia. You should be under anesthesia. Somebody said, I am on Facebook, Jessica, I am on Facebook for the dots. Okay, anyway, so let's talk about hydrodistension. So you're under anesthesia. It's an outpatient procedure. It's very quick, 20 minutes. What they're going to do is catheterize you. They're going to fill your bladder with fluid, keep it in there for a while, drop it and then empty it out. And then they're going to fill it up again, keep some fluid in there again, empty it out. And then they're going to take a look at the bladder. They might even look in the bladder when there's still fluid in there. And when you do it that way, it allows you to look more closely at the bladder wall and also do biopsies and anything like that if they see anything that they're deeply concerned with. And so the challenge with the hydrodistension is because it's stretching the entire bladder, it's much more painful. That's why it's done under anesthesia, and your post-op recovery can be rough. Now, I mean, well, it can be. Emphasis on can. Some people have a hydrodistension and they go out to dinner that night. Other people have a hydrodistension and they're in bed for a week because when you stretch the bladder, it's quite painful. All right. Lalina says, thank you. Thank you, you guys. Karen Matz, that's what I'm worried about with the cystoscopy, and I'm allergic to morphine. Had a hydrodistension. Karen says, had a hydrodistension, made my symptoms worse, also extremely painful. So Karen, hydrodistensions used to be done what we call high pressure, long duration. So what they would do is fill up the bladder and stretch it intensely, and then leave it stretched for like 20 minutes. So high pressure, long duration. But we know that the bladder can be injured when you do that. And in fact, some of you, your bladders years ago were ruptured. Today, if you look at the American Urology Association guidelines for how to do hydrodistensions, they are done under a low pressure, short duration. low pressure, short duration. So that means they don't use as much water and they don't hold it in as long. And the goal here is to not damage or irritate the bladder. So if you had a hydrodistension and you were significantly worse afterwards, that's when you ask the doctor, okay, what'd you do? Or better yet, if you're scheduled for a hydrodistension, you need to ask your doctor a couple of questions. Number one, how do you intend to do it? Are you going to do high pressure or low pressure? And if they say, I'm just going to do it, you don't question me, you're going to like walk away from that doctor. They should know since 2011 that the American Urology Association only recommends low pressure, short duration hydrodistensions. And if they intend to do it high pressure, I would get your tush out of that doctor's office. The second thing you've got to have in that discussion is in that consultation, is a discussion about pain care. Because when you have a hydrodistension, there is a chance that it could hurt. And it's important to have a pain management plan. And so this is not a year's worth of codeine or even a month's worth of codeine, but you might need a slightly stronger pain med for a couple of days afterwards. Norco, something like Norco. And then the third thing you've got to understand about a hydrodistension is that this is when they look at the bladder, and if they see an issue, they normally act on it. So if they find a hydrodistension, if they find a Hunner's lesion, they are supposed to treat it at that time. They either laser it, cauterize it, fulgurate it. That's all the same thing. You basically heat up the tissue and kill that nerve, or they inject a steroid into it. There is nothing more tragic for the IC patient with Hunner's lesion. It's to have a doctor say, yeah, you got Hunner's lesions, and not treat it. Because guess what? You're going to have another hydrodistension to treat it. So, and that's always really, really sad. Hold on, my
front page.
What?
Front page of the paper.
No, I haven't even seen it today. Drink some water. That's my 97, soon to be 98-year-old dad looking for the front page of the paper. So anyway, if they find Hunner's lesions, when they do a hydrodistension, they're supposed to treat them. You're supposed to treat them at that time. For patients who call our office who are in long-term chronic pain, I will tell you, I can't even begin to tell you how many of them have lesions that were never treated, and it breaks my heart because you suffer. These are big open wounds in the bladder that urine is irritating every day. If you seal the wound, if you cauterize the wound, then the lesions get better. Or if you inject it with a steroid, the lesions get better. Somebody was just asking, is vitamin C, vitamin D, and zinc irritating for the bladder? Vitamin C is. D, no. D3 is fine. Zinc is usually fine. But vitamin C in the form of ascorbic acid can be very irritating to the bladder. That's why you want to look instead for calcium ascorbate, also known as a buffered ester C or a low acid vitamin C. And I just ordered a whole bunch of low acid vitamin C in our store. We're just bringing in a whole new vitamin line, and they're in the warehouse, and I just haven't been able to add them yet. Deb says, you've hit me spot on. A 10-year sufferer, one urologist. Last visit, I was in so much pain, which was pelvic mostly. Oh, and darn it, it just moved. Hold on. That's a challenge with Facebook, is I can't go back and read your feeds, and you guys talk so bad. Hun, I'm sorry. Just as I was reading it, it disappeared. Juniper says, can you talk about endometriosis? I think I might have it with IC, and I'm worried about the cost of a laparoscopy. Well, endometriosis is real. Endometriosis is tissue that migrates from your uterus up through your fallopian tubes and into your belly. It can land on your bladder. It can land on your bowel. And the challenge Helen just said she had Hunner's lesions treated with steroids, and she has wonderful relief. Yay, Helen. Yeah, baby. That's good. All right. So getting back to endo, the challenge with endometriosis is that tissue, when it's in your abdominal cavity, is very tough. It's tight. It creates adhesions. It's hard. And so if it starts to wrap around your bowel or wrap around your bladder, or it can even migrate up towards your stomach, even up towards your lungs. It's been found up outside of your lungs in rare cases, but it can. That tissue is challenging because it can wrap around blood vessels. It can also migrate through tissue. So if you have endometriosis on your bladder, it can grow into your bladder and inside of your bladder. And so if you have extremely painful periods, it would be perfectly reasonable to let them look. I let them look. I had I was convinced that it couldn't have been my bladder. And so I had a laparoscopy in September of 1993. And I needed that. I needed to know. Jessica says, can we use wet wipes? The answer is you got to be really careful with wet wipes. Cottonelle, Cottonelle's pretty irritating. I use Preparation H wipes occasionally. Somebody said, what about estrogen? If you are older, if your symptoms began after hysterectomy or you are just older, understand that your bladder relies on estrogen to produce that nice thick coating of mucus. And unfortunately, that mucus is estrogen dependent. So when you're young and you have lots of estrogen, you have lots of protective coating, you have lots of mucus. When you're older, you have less estrogen, you have less mucus. So your bladder's ability to defend itself is now compromised. We call that the genitourinary syndrome of menopause or vaginal atrophy or estrogen atrophy. So in those cases, absolutely, using a topical estrogen product can be stunningly helpful, especially for urethral pain. I was working with a patient yesterday. Oh, I had so many phone calls to return this week from our power outage. So I was on the phone all day yesterday. And, time and again, it was yet another patient. Her symptoms were in her urethra. Her urethra was burning badly. And the doctor gave her estrogen last year. She never used it. She didn't understand why it was important. Estrogen can be very important, and know that topical estrogen is considered remarkably safe. Google it. Google the safety of topical estrogen. Faith says, been taking Bladder Builder for a few months and it is definitely helping. I missed a few days when I ran out and darn it, Faith, it disappeared as I was reading it. I'm glad it helped. And so keep using it. Jessica says, are we to use high pH water to rinse down below? No, just use water. You don't need to use fancy water to rinse down below. Tap water is fine. Carla says, remember me? I know you talked to a lot of people. Namibia, you gave me great advice about 3 weeks ago. Although I'm here in Africa, the urologist I went to is originally from the United Kingdom. I gave him the info on Elmeron. He was pretty impressed. I got hold of, oh yeah, girl, I remember you. Yeah, totally. I got a hold of the glucosamine chondroitin in my local shop, but the quercetin was sold out. Unfortunately, a few days after I started it, I got severe diarrhea. Ooh. That's not good. When we talk about trying to protect and help the bladder wall, that's what Elmeron did. Elmeron was a bladder coating, but now Elmeron is linked to pretty severe eye disease. So Elmeron's patients are going off of Elmeron now. So what are your options? You can do bladder installations, a heparin lidocaine installation, also known as a rescue installation, or you could even do an Elmeron installation. Because when you put it directly in the bladder, it does not become systemic where it gets into your bloodstream and potentially would reach your eyes as if you were taking it orally. The other option is to go to a chondroitin-based supplement. But the challenge here is, number one, quality, and number two, sensitivity. And Carla, I think we talked about that a little bit. All of the chondroitin-based supplements, every single one of them, are known to cause a loose bowel in some patients. Not everybody, but in some patients. And I'm one of them. I could take one Cystoscopy a day and I'd be fine, but I couldn't take two. As soon as I took two, it gave me a loose bowel. That's why we always say start slow, start with one, just see how you do. But quality is also really, really important. And that's where I kind of hesitated because I don't know what is available in Namibia and in Africa in general. Look at the ingredients, look at the source. The chondroitin should be sourced from chicken. We don't want it sourced from shark fin. And the glucosamine might be coming from shellfish. And maybe you have a sensitivity to shellfish, and maybe that's why you had an even stronger gut reaction to it. But you're not alone in that. That's something we've seen with every single supplement, but it's only a small group of people. But girl, I'm one of them. So that's when I take a supplement, I just take one. I never go more than that. So look at the brand. And then, if you want to take a picture of the bottle, you can send it to me. I'd love to look at it. Amanda says, do aloe supplements help? The answer is yeah, for some patients they do. There's a very early on for me. I had a mother with a 4-year-old son who had what they thought was IC. And of course, his language skills were so low. All they could say is all he could tell his mom was that his pee-pee hurt. His pee-pee hurt. And so they gave him there's an aloe drink, George's Aloe, which is an aloe drink that's really the best regarded liquid aloe that you can buy, and it made his pain go away. So aloe is known for being kind of soothing. The challenge again with aloe is that for some people there is gut intolerance for and so if you've tried aloe and you had a strong stomach or gut, then the odds are you're not going to be able to take aloe. If you don't, if your body tolerates the aloe well, we've got a lot of options. You've got Desert Harvest aloe, and now we have, Aloe Path. Where'd I put it? And I'm particularly excited about this one because so many of you, and myself included, have not been allowed to have pain medicine. And the reality is that organ pain, bladder pain is intense. It's characterized by being relentless and difficult to ignore. There are moments when using a little bit of an opiate it makes sense. And back before the opiate crisis, we were allowed to have a little bit of pain medicine. Today, not so much. And so to have something that contains PEA, palmitoethanolamide, in it, which we have a research study from Italy showing that it can help dramatically improve the pain of IC, is important. So I'm particularly excited about Aloe Path. It's the only supplement that combines organic aloe with PEA. Jerry says, any suggestions for pain that radiates up to the kidney area? My doctor said your kidneys don't feel pain, so it doesn't really. What? Then why do kidney stones hurt? Wow. Okay, let's try this again. Any suggestions for pain that radiates up to the kidney? My doctor said kidneys don't feel pain, so it doesn't really hurt. I explained that when my bladder gets full, a full feeling and gets painful, my back where my kidneys hurt quite badly as well. So, hon, that could be your psoas muscles. Your psoas muscles are the muscle. You got two. They're big ropes. They're like literally this big, and they go down your spinal cord, and then they anchor in the pelvic category. In the pelvic cavity. And so, if you're having a pelvic floor flare, you could be having a psoas spasm. I know that when I get low back pain, it is almost always on my left side, and it is almost always my psoas. And I wear heating pads. I'll wear 2 or 3 heating pads up the side of my spine right there to try to get that out of spasm. So I think it'd be really interesting to have a pelvic floor assessment and see if that could be your psoas. So Jessica says, my bladder doesn't usually hurt. It's mostly your pelvic floor and your spine. Right. So we have to look at other orthopedic stuff. So guys, did I tell you? I don't remember because we haven't done a meeting for 2 weeks, right? And I think 2 weeks ago, I told you about a brand new study that came out about men with testicular pain and scrotal pain. And remember, what do we say? There are moments when you have to look beyond the target organ to try to find the problem, right? So this was a study of men with long-term chronic testicular pain. 70% had a hip problem. That ultimately, in the end, it was an abnormal hip muscle issue that was driving their pain. So we always want to look beyond the bladder to other structures in the pelvis that could be triggering some of that pain. Catherine says, humbling it after years, a long period of stability, you turn your inner, oh, okay. You went into a massive flare. Oh, dang it. It keeps, you guys, you're talking so much. It's feeding so quickly. Oh, okay. I didn't quite get your humbling experience. I'm sorry. You guys, I am simulcasting right now on Facebook and YouTube. So I've been looking at our Facebook feed. When I look up here, I'm looking at Facebook. When I'm looking down here, I'm looking at YouTube. And YouTube, I am sorry that I have not been looking at you. Let's do that for a moment. Carol says, hold on a sec. Carol says, I've been battling chronic UTI for 4 years. Now I have a constant burning in a specific spot in my bladder and in my urethra. Could this be Hunter's lesions? How did they diagnose and treat? You know, anytime you can point to a spot, that's meaningful. That's important. And you have to bring that spot to the attention of your doctor and let them try to figure that out. Because sometimes the spot can be a trigger point. Sometimes the spot can be a Hunter's lesion. And so how would they do that? You would let them do a cystoscopy and look there. Most IC patients don't have a spot. So like I was working with a wonderful guy who has now become a dear friend of mine, who called like 6-7 years ago. Actually, he emailed me, and there's just something about his email that just really broke my heart. And I emailed back, and now we're very good friends. For him, it was always a spot. There's like, it's right here. It's a spot. And I kept saying to him, dude, we have to understand what that spot is, because that's not consistent with IC. IC patients don't normally have a spot. And it took him a while, but when they finally went back in and they did some exploratory surgery, what he had was gangrene in one of his ejaculatory ducts. So it wasn't IC at all. It was gangrene, and it was from a botched surgery, early surgery. So I say investigate the spot. That's important. Carla says, I have a hysterectomy 3 months ago, cystoscopy and biopsy 6 weeks ago. I totally dried out from head to toe, been on estrogen for a month. Neither me or my GP are convinced I have IC since yesterday. I have what feels like a yeast infection. So, Carla, you are a genitourinary syndrome of menopause patient, also known as GSM. And so, you got to do some reading on that. You've got to do some reading so you understand the symptoms and also understand what happens with aging as you get older, because especially in your vagina, the pH changes. And, you can have a lactobacillus infection. The lactobacillus might become an overgrowth, but you also could have a fungal infection. You could have a next generation DNA test on your vaginal swab and see if it grows out anything. Patty says, my bladder's never hurt either. My pain seems to be in my pelvic floor. A hot soak will make the pain ease. I'll be seeing a urogyno in October, so hopefully I will learn more then. 4 years ago, I was diagnosed with IC. Now I'm wondering if it was a misdiagnosis. Patty, you have to get this book. Everybody with muscle issues, You have to get this book. It is free on Kindle Unlimited. No excuses. No excuses. If you want the print version, it's in our store. I recommend the print version because, I mean, seriously, you got to study this. You have to understand your anatomy so that when you go to the gynecologist, you can say, all right, is it my levator muscle? Is it my piriformis muscle? Could it be a nerve segment? All sorts of things. This book is a master class in pelvic anatomy. And it's literally the best book I have ever read. This is an important chapter, tricky trigger points. So now listen. If you have fallen, if you have broken your tailbone, if you were raped, if you were abused, if you were a ice skater or a gymnast or a bike rider or a paratrooper or a football player or a wrestler or a motorcycle rider, if you have had a series of pelvic traumas, and you might not even know you've been traumatized. Yeah, you fell. Okay, you fell, but you got right up. Life goes on. You might even had a little bruise, right? But life goes on. You don't necessarily understand the toll that that's taking. Whenever you suffer an injury, especially a compression injury where you fall, think about it. 150 pounds are landing on a 4-inch square, right? Area of your muscle on your butt. So your muscles are compressed, your blood vessels are compressed, and that's, of course, what causes bruising is because the muscles get broken when you fall, but the nerves also get damaged. But the legacy of every single fall like that is you might develop a trigger point. And here's the problem with trigger points. I want you to see this. So y'all know what a muscle knot is, right? You know, when you have a muscle knot on your back, what do? You have somebody push on it. Right? You roll in a tennis ball that you know that when you push on the trigger point, it usually releases. It might take some time, but it usually releases. All right. Here is a trigger point. So look what it's doing. A trigger point becomes basically a long-term compression injury. And as that muscle fiber is contracted, what is it doing? It is squeezing blood vessels. So look, you have a nice, healthy, thick blood vessel here, and look at how much thinner it is here. It's reducing blood flow to the tissues. And it's also messing the nerves up. The blood vessel, the nerves need blood flow to function normally. If the blood flow is compromised, then the nerves will not function normally, and the nerves will be an issue. And so dealing with these trigger points is critical. Somebody said, is B complex irritating to the bladder? If it has B6 in it, yes, it is irritating to the bladder. I love this book. I love this book. I love this book. And you guys, when I study new things, I mean, this is my job, obviously. This is a full-time job for me. The way I learn is I have to learn with colors. That's just my brain, how my brain is wired. That's why my office is all sorts of colors. So I literally, for me to absorb the information, I have to color it. So you can see I colored the muscle, and then I colored the trigger points so that I understood what I was trying to do. Even on this one too. So I'm really understanding where the trigger points happen in the rectus abdominis muscle, right? They happen down here. The trigger points in the hamstrings, you can see they happen often on the inside of the thighs. This is such a good book. Oh, look at this. How many of you are bike riders? Look at this picture. So here is a bike seat, right? And you can see how that bike seat is pushing. There's not a lot of protection there, my friends. There's not a lot of muscle or fat there. So that bike seat is pushing immediately up right into your pelvic cavity, right onto your levator muscles, and right onto the nerves. That's why people get bike rider syndrome. If you look at those professional bike riders, they're numb down there. A lot of them are numb because of the long-term nerve injury from that. All right, let me look at YouTube here for a moment. So Facebook, you guys don't be offended if I don't get your question, just ask it again. It just flies by. Y'all are so good at helping each other. I am just, you inspire me every single time I do these. Hello, YouTube. It's nice to see you. All right, here. So let's, now that I've moved you up. Catherine, humbling experience. Oh, Catherine, I'm so glad you're over here. Now I can see your question. Massive flare after a years-long period of stability. You're due for a fulguration. Hunters and turmeric snuck into food. Inner stem turned up full, pain meds. Any advice on rescue instills? Well, yeah, I mean, definitely try rescue instills. I mean, heparin lidocaine would be the one to do. See, it would be very interesting to see if that would be helpful. Over on the IC Network website, I have in our installation area. So if you go to the treatment pull-down menu and you go to step 2, and then you go to the bladder installation treatment area, I have all the formulas that have been published on the various installations. Doctors like their own formula, so doctors get creative, but I've given you 6 or 7 or 8 potential formulas. Donna says, the book Jill is talking about is crucial. I have it and I take it to my PT and my physicians. Is it, Donna, right? Like, right. This is the book that finally explains it all. It's amazing. This doctor, Dr. Jerome Weiss, is now 81 years old. And it took him 15 years to write this book. Pelvic pain specialist in San Francisco. Nicest guy in the world. I've met him several times. I had no idea he was writing this book. It is phenomenal. It is a love letter to his pelvic pain patients. Now that he is retired, he wanted you to be able to have a resource that you could use as you seek answers to your long-term persistent pain. You know, think about it, guys. Think about it for a moment. What about all those patients who did Elmeron for years and they never got better? Why? Why didn't they get better? Because for a lot of us, IC is not a bladder wall issue. For a lot of us, IC is a muscle issue. It is. It is. We knew that in 2008 when the first National Institutes of Health peer-reviewed study, multi-center study on pelvic floor therapy proved that pelvic floor physical therapy outperforms oral medication in many, if not most patients. So we knew 12 years ago that pelvic floor muscles are critical to this. Critical to this. And if you go back 100 years and you look at the papers published on IC, they talk about muscles so tight, they're like tight piano strings. But because they're urologists, they didn't over their head. Yeah, she's got muscle tight. She's got muscles so tight, they're like piano strings. But hey, let's focus on the bladder. Look at how far that got them. That's the tragedy here. That's the real tragedy here. Patty says, what's normal range of estrogen? I don't know off the top of my head. Ultimately, though, Patty, to me, it's all about what does your skin look like? And that's what my gynecologist said to me, is let's look at your skin because we can see what dry skin looks like. Amanda says she had endometriosis on her bowel and her bladder. I'm so sorry, Amanda. That is just, Effie says, does anybody get low back pain with their affairs? Yeah, hun, it's usually, the low back pain is usually a contraction of the psoas muscles. And, you know, in this handy dandy, and the quadratus lumborum muscles. So here's a picture. Let's see. Oh, it's so hard to do this. So here are your psoas muscles. So look. They attach at the top of your femur, and then they go up through the pelvis and all the way up through the low back. And look at all the vertebrae. Like here's your sacrum, and then 1, 2, 3, 4, 5, 6 vertebrae up. So when your pelvic floor is in spasm, when your pelvic floor is contracted, the psoas muscle is contracted, and that's usually what causes the low back pain. Also, you can look at this here. Here's another group of muscles, the quadratus muscles. So these muscles can also be a source of pain. Listen, when you're in pain, your body tries to protect you. How does it try to protect you? By tightening muscles. It's called the guarding reflex. It's completely subconscious. You cannot turn this off. When you're in pain, your pelvic floor is going to get tight, and that's going to pull. Because your pelvic floor also goes up into your lower back, you're going to have low back pain too, potentially. Evie also says, can anybody out there get flares from B vitamins? Absolutely. On B6 is a well-known irritant. We're fine with B12, the other B12s, but the B6 is irritating. Hi, Lorraine. It's nice to see you too. Hi, Eric. Eric says, my symptoms have become so confusing. Well, Eric, tell us about them. Jessica says, I went on continuous birth control under supervision of my gyno for 10 years in my 40s and knocked out those 2 flares every month. Yep. Sandy says, my sister and I have bladder issues. Sadly, she's severely disabled and nonverbal. There are days when she screams in pain and draws her legs up. She's in the, let's see. She has a history of chronic UTIs, but these screaming bits are so hard. You know, one of the, being a support group leader is heartbreaking sometimes. And Sandy, I worked with a mother whose daughter had cerebral palsy with IC, and it was completely nonverbal. That's what happened with her too, is that she would bend over and she would scream when her bladder was hurting. And that's when it gets so tricky. So obviously, because she's nonverbal, you're going to have a very, very difficult time trying to differentiate between a UTI and bladder symptoms. And hopefully you've got UTI test strips. I just bought a whole bunch. They're in our store again, guys. So you could, use a test strip to look at her urine. And if she's got positive nitrite, she's got infection. That would be a must every single time. That would be something that I would be doing for sure, 100%. For something like chronic UTIs, having that next generation urine test is important so that they can identify, number one, is it a bladder or a fungus? Because we now know, again, from our own National Institutes of Health, that some of you you're flaring because you have fungus in your bladder. You have candida in your bladder. And again, that's from the National Institutes of Health funded MAP Research Network. We knew that 5 years ago. Don't assume when you've got symptoms of infection, it's bacteria. It could be fungus and it could be virus. So Sandy, doing something like a next generation DNA urine test would at least give you a baseline. It would tell you what's there. It would tell you good bacteria, it would tell you bad bacteria, and it would tell you fungus. And to me, that's data. That's important data. Make sure that if it's not UTI, hopefully they've done a proper workup, they've ruled out Hunter's lesions and stuff like that. Diet modification is going to be critical, along with maybe supplementation if she can swallow pills. I don't know if she can swallow pills. That's tricky. That's very, very tricky. So that might be a case where the George's aloe drink, if she can tolerate aloe, might be particularly useful. Lisa, right above you, said that George's aloe is the best for heartburn. So George's aloe is out there for sure as a possible option. And if she can swallow supplements, then maybe you could do something like Bladder Builder or Peora, something with PEA in it that might help reduce some of that pain that she's got, right? I'm so sorry. We have the same issue with IC patients in nursing homes and assisted living. I had a sweetest older lady called me from her bed in a nursing home crying. And the dietitian was giving her coffee and orange juice every morning. And so you can imagine that by noon she was sobbing in pain because they would not give her anything else. And she was in agony. And then her son called me and, please help us, help us. They don't understand coffee and orange juice is bad. So I finally got the dietitian on the phone for the entire facility. And I said, do you know what interstitial cystitis is? And she said, no. And I explained it. And I said, listen, you cannot give this patient coffee and OJ every day. They will be a lunatic. You will be sedating her, which they were. And I suspect they do that to a lot of patients without understanding the consequences of that. Anyway, it worked. They stopped it. I mean, I spent a lot of time. I sent them a lot of educational materials. I made my case. I helped them understand that what they were doing was hurting that patient. And she called me back and she said, "You're the only one. You're the only one who helped us. The only one." And she died a couple years later, and she actually left me a small donation in her will. her son called me and said, "Well, Mom died," and I was like, "I'm so sorry." She goes, "But you were the only one who helped her, so she actually left you something in her will," which was just like, oh my God, wow. And I said, well, I don't want to take that money. It was $5,000. I said, I don't want you to take that money. That's your money. And he's like, no, she wanted you to have it. And I said, well, no, this is what we're going to do. And what we did is we dedicated that money to outreach for seniors in convalescent hospitals. And that's kind of one of my passions. And so that's what we did. And I haven't worked probably in 5 years now. I haven't worked with a patient in a convalescent hospital, but always happy to try to help. You know, imagine screaming in pain every day and nobody listens, or screaming in pain a day and you can't tell them what's wrong. Those are the stories that break my heart. And anything we can do to help, we have to do to help them. That's why we have IC Awareness Month. It's IC Awareness Month, September right now. Our theme is share your story. Your voice matters. We have got to find those patients who are suffering in silence, like that elderly woman, and help them. Evie says, B12, B6 are irritating for me. B12 shouldn't be irritating for you. B12 is not an irritant. B6 is the irritant. I mean, we all have sensitivities, but I'm surprised that you're reacting to B12. Jennifer says, I'm going to message you, Jill, to help others with my evaluation results. I don't want to have suffered like this for nothing. Girl, absolutely. Love to see it. It's interesting. I'm really surprised that B12 was irritating. Understand too, my friends, that listen, multivitamins are the kiss of doom for an irritated bladder. You're not going to be able to take a Centrum or a one a day or any vitamin like that. Because remember, those mass-produced vitamins use the cheapest ingredients they have, and the cheapest source of vitamin C is from citrus. So I personally have been up all night after trying a Centrum or a one a day. And so the only vitamin that you're going to be able to get away with, most likely, is going to be a low acid multivitamin. And that's going to be Bladder Smart. The Bladder Smart low acid vitamin right now is, we used to sell Multi-Right, but Multi-Right, the pills were very, very large. People were having trouble swallowing them. And so I asked Natural Approach Nutrition if they would make us a new low acid vitamin, and they did. And the cool thing about this is that it's in a capsule and it's easy to swallow. You can take from 1 to 3 a day. I always take 1. I never go up. And I've never flared. I've never flared with this vitamin. Never. And I will always flare with a Centrum or one a day. Do I have something on my eyelid there? What is that? All right. Jessica says, will microgen show fungal infection? Absolutely. That's why it's so good. Patty says, I have the book and read it. I'm planning on rereading it before my appointment. Yeah, good. Good. Jennifer says, my physical therapist says my muscles are tight and the doctor says walking keeps my pelvic floor muscles tight. So what can I do? So Jennifer, this is exactly why this book is so important for you, because he introduces a concept that no one else had ever introduced before. And that is a mechanical injury, So anytime, so what fascinated Dr. Weiss, and here, let me just adjust my computer here, is that he became a master at relaxing muscles. Man, if you walked into his clinic with trigger points, you would walk out of that clinic with normal muscle tone. If you walked into that clinic with nerve issues, he was very good at calming nerves down. But what fascinated him was why did they come back in the same spot? It's like, wait a second, man, I just worked an hour on you a week ago and they're back? Why? That doesn't make sense. Why would they be back? We fixed them. And he introduces the concept of a mechanical injury, that there is something else happening in your pelvis or in your legs, which is triggering long-term chronic muscle tension. And so it makes sense to look at your SI joint. My dominant issue is my left SI joint, okay, which keeps my piriformis muscle tight and spasming. It makes sense to look at your hips. Again, we've got the new study that shows that 70% of men in that study had it with testicular pain, had a hip abnormality that they had to fix. And it also makes sense to look at the knees, because if you got a bad knee, you're not walking straight. You know, you might be limping, which would be tilting your pelvis. But the chapter in this book, which is going to blow your mind, is the chapter on the feet. Because how you walk is going to be referred directly into your pelvis. So if you have one leg longer than the other, then your pelvis is tilted. If you overpronate, where your ankle tilts outward, or you supine, where your ankle tilts inward, that is going to influence your pelvic floor and cause your pelvic floor to be tight. And here is a picture. I want to see. All right. Oh, okay. Hold on. Okay. Oh my, it's so hard to hold these open. I just need to photocopy. So look, here is somebody overpronates, right? So look, the ankle is pushing inward. And here's the normal one. So look at the normal leg for a moment. The weight is going straight up the muscles and the bones, and you can see how it reacts and hits the pelvis and what happens with the femur, right? Now look at this one, the overpronation. You will see as it goes up, the femur, the bone, is pushed outwards, and the muscles attached to the bone are also pushed outwards. And what is that doing? That is causing obvious, clear imbalance between the left and the right side. And that's putting stress on your piriformis. That's your piriformis muscle right now. That's putting stress on your piriformis muscle. And that long-term chronic dysfunction, you know, when you're young, because you're usually born with one, you might be born with one leg longer than the other, your body is really resilient. You know, you don't necessarily know. But when you hit your 30s and your 40s, that's when you see the toll of cumulative injuries. And at some point in time, these muscles become weakened and they become a bit damaged and stressed, and they can start spasming and yada, yada, yada. And so, Jennifer, the question you've got to ask your physical therapist is not why walking is keeping your muscles tight. It's like, what's wrong with your bony structures? What's wrong with the way that you're walking that could be causing these muscles to tighten? Do you have a foot disorder? Do you have a knee disorder? Do you have a hip disorder? That would explain why walking is keeping your muscles tight. And understand that in his clinic, Dr. Weiss's clinic, for those he had that group of patients whose tension came back over and over and over again. What he was able to determine is 90% of those had a foot issue. And when he sent them to podiatry and they got the feet fixed, what do you think happened? The pelvic floor muscles improved dramatically. So, this is like where we say with IC, look beyond the bladder. Well, with the muscles, sometimes you have to look beyond the muscles at the skeleton. And let's see if there's any abnormal skeletal issues like scoliosis or SI dysfunction or a bad foot or a bad knee. That could be an issue. I've been working with one patient who was born with a birth defect on a foot. And her muscles are rock hard tight, and trying to address that is really hard for her. But at least we know, at least we understand why her muscles are always so tight. Okay, listen, it's 2:00. So this is normally when we begin our Zoom meeting. So I'm going to keep Facebook open and YouTube open, but I'm also going to open up Zoom and we'll start a Zoom meeting. And this is where you can ask your question. Everybody will hear, and you will get a mini coaching session from me. So give me a moment here, and I got to drink some water. Hold on. I was out in the smoke yesterday for about a half an hour. Oh my God, it was so stupid. I should not have gone outside. I was doing a coaching on the phone, and I just had to get out and move while I was talking to this patient. And I breathed so much smoke in that I irritated my throat. And my throat is like so unhappy. I started coughing on the phone with her. My tonsils are irritated. Everything's irritated. All right, so hold on a sec. Okay, so guys, we're going to take a bio break. Y'all, the great thing about online support is you can get up and go to the bathroom anytime you want. It's cool, right? It's wonderful that way. This is our scheduled bio break for 2 or 3 minutes. If you need to go up and get a drink, go for it. You need to go to the bathroom, go for it. Let me set up this Zoom meeting, and I will give you the invites for the Zoom meeting. And then I need to go take a bio break too. So hold on a sec. Let me do this. Hello, Zoom. All right. All right. The meeting has been started. Let me turn the camera on. Start video. Yay! Boy, I look like crap today. Sorry. It is what it is, guys. This is life in the fires. All right. And let me get that invitation here. Okay. So for Facebook, you guys, I'm going to miss a whole bunch of your questions. So you're going to need to ask them again. And so Facebook, here is your Zoom invite. On YouTube, where did my YouTube go? There is my YouTube. All right, YouTube. There you go, my friends. Let me know if you need a I don't think you'll need a password. I think it'll bring you right in. And I'm going to go take a quick bio. I'll meet you back in a minute. And let's do this. It's time for you to share your voice in IC Awareness Month. doing my meeting. I'm not available yet. Doing my meeting. Remember we had an arrangement when you were making me mad. I have got Hamilton on my brain. I absolutely love King George's song. I have it memorized and I sing it all the time right now, which is what I do with music. Anybody song over and over for 2 weeks and then you move on to something else? That's me. All right, let's see how we're doing with Zoom here. Hold on a sec. Awesome, 10 of you waiting. Hi, Sarah. Hi, Evie. Hi, Jessica. Carol, Eric, Tia. Hello, Donna. Hello, iPhone, whoever you are. Mary, hello. All right, and so I keep people muted until I call on them, okay? So that we don't hear stuff in the background like dogs being and all sorts of stuff like that. So please keep yourself muted. That would be very, very, see, there's somebody right there. Hold on, we got to mute you. All right. Okay, so for Facebook, YouTube, guys, I'm not going to be looking at that stream right now. So if you can just bear with me, we're going to let these people have an opportunity to talk. You're going to hear how I work with patients. You're going to hear the equivalent of a coaching session with each one of them. Let's see what we can do. Let's see, let me just see if there are any last questions. I apologize in advance for everybody in Zoom. Please know that I'm going to stop you frequently and ask you questions because I have to try to understand your body before I can talk about treatments. And so if I ask you a question you don't want to answer, that's fine. Just say, I'd rather not go there publicly. That's fine. No, please know that I am available privately too. I do coaching all the time. You just call our patient support line. Many times you'll get me and it's entirely free. But if you want to spend a lot of time, I might ask you to sign up for a coaching session or make a donation to the IC network. All right, so hold on a sec. So we are let me just set my computer up right here. All right, hello, you guys. There you are. There you are. All right, I'm going to go to Eric first. Let's see, Eric, I tried. Hello, Eric. How are you doing today? How is life?
Jill, first of all, I want to thank you for what you do with sessions. It's amazing. And I feel very much at home with the other people, even though I'm a guy. So I just wanted to say that first. So my issue is the fact that I'm still dealing with the pelvic stuff. Now, let me say this. I am 3 weeks on a regimen of antidepressants. So
okay.
Those in the past have done a good job of calming my nervous system. Although, because I'm experiencing a lot of symptoms, of course, I'm fearful that, maybe they aren't going to work. But my issues tend to be more, for instance, there's times when I'll be sitting on my butt, I guess, in the perineal area, and the pelvis will feel compressed. The penis will feel pain. Sometimes after urinating, I still feel like it's dripping, but it's not dripping. And it's these sensations. And then there's times too when I'm not sure if I need to void or if my bladder's really full. It becomes kind of confusing. And I start to go to places like, oh, do I have pudendal neuralgia? Do I have, I'm a catastrophizer. So
aren't we all? Aren't we all at times? You're totally human. That's okay.
I just kind of always go to the worst scenario. And And I don't know how to cope with trying to figure my way through it. I started to read Diagnosis' book, and that anatomy chapter is thick for me, meaning it's, concentrated material.
Yeah.
And so I've been trying to do some stretching, some short walks, but I think part of me wants to know how to fix this. Part of me is really scared and nervous and anxious. So I don't know how to approach everything. I don't know if I should just wait to see if the antidepressants kick in, or should I try to find someone to help me? It's all very confusing, and I don't know how to navigate my way through everything.
Okay. So number one, you're not alone. Number two, we've all been there. Number is real, and it's important that you nip that in the bud. You have a negative thought, you give yourself a jolt of adrenaline, which then drives more anxiety, right? So, I've got a great video on anxiety NIC on our website, but so here's the routine. Every time you have a negative thought, first thing you do is close your eyes and visualize a stop sign. Just stop your brain for a moment, okay? Then take a nice, slow, deep breath. In for 3, out for 3. Okay, let's do it again. In for 3, out for 3. So here's the cool thing. When you have a negative thought, you give yourself a jolt of adrenaline. Oxygen turns the adrenaline off. So that deep breath completely minimizes and deactivates the adrenaline jolt that you had. Okay? So here's the problem with catastrophizing. And you're talking to the queen of catastrophizing here. I mean, it's like every thought is negative. It's like, oh my God, it's never going to go away. Oh my God, nobody's going to love me. Oh my God, my house is going to freaking burn down. Oh my God, I have nowhere to go. Oh my God, oh my God, oh my God, oh my God, right? Each time you have a negative thought, you give yourself a huge burst of adrenaline. And adrenaline is a fight or flight response, right? That's what tells you to run or flee. But there's nothing to run or flee from. So what's happening is you're just getting higher and higher and higher levels of adrenaline in your body, which is making your heart race. And it's just, you end up spinning. You're in this adrenaline spin. And this is what a wonderful class taught me. So our goal here is to chemically neutralize the adrenaline. If we do that, everything calms down. Everything will calm down. But it takes work. So here's what you do. Negative thought, stop sign, deep breath, and then minimize the thought. You have got to remind yourself it is a thought. It has no power. And what I say to myself is, oh my God, Jill, you're not God. You can't predict the future. For all we know, this house is going to be here for the next 100 years. Why do you think that? And you don't even ask why. It's just like, you're not God. You're not God. You don't know if that's going to happen, right? Okay, so in the class, they taught us this, and then they warned us. They said, you're going to leave here. Every single time you have a negative thought, do it. You're going to do it hundreds of times because you have no clue just how frequent, like every other thought in your brain right now is being driven by adrenaline. It's just being driven by adrenaline. So they sent us home and literally started walking out. Like for me, I started doing it as soon as I walked out of the class, pretty much. And I did it hundreds of times in the first 24 hours. And when I really paid attention, it was like, oh my God, I didn't even know that everything I was saying to myself was negative. And then the next day, I was doing it half as much, like 50 times. The day after that, I was doing it like 20 times. 4 or 5 days later, I was doing it once a day. I have not had an anxiety attack since I took that class, and that's through a very long uterine cancer scare a couple years ago. So learning to control that adrenaline is important, and that will help tremendously. Stop sign, deep breath. Stop sign, deep breath. Minimize the thought. Just get used to doing that, okay? It will help. I promise you, it will help. But your question is, should I go talk to somebody? The answer is, yeah, why the hell not? You know, you're not alone. You don't have to do this alone. There are people, and God didn't give us the skills to deal with IC and to deal with fires when we were born. It's about skill building. We have to learn new skills. And, you know, one of the things that I had, you know, the reason why I had developed anxiety disorder was because I had, when I was a kid, I had a rapist murderer in my neighborhood who attacked me and killed my neighbor. So I lived with constant anxiety for years and years and years. And I wasn't afraid to leave the house, but I was afraid all the time. And then finally one day it was like, oh God, I can't do this anymore. Please help me. And I found this class. I was worried that I would have to go through extensive therapy to figure out what the hell happened to me in my childhood to make me anxious, when I already knew that. I already knew exactly what the problem was. And so when you go and talk with an anxiety specialist, you got to understand you're going there for skill building, and there's no shame. In my class, we had the first lottery winners in the state of California in my class. They won all the money. It made them terrified. So, and there were people who didn't want to drive across a bridge. There were people who didn't want to walk into a crowd. There were people who were, you know, I mean, but when you go, it's like when you go to an IC support group meeting, when you actually walk into a room of your peers and you look at them, and like you can on Zoom right now, you see we're normal people. We're normal. We're just in an abnormal situation. In your brain, you're thinking there's something wrong with you. There's nothing wrong with you. You're just overwhelmed right now, and there's some skills you could learn that would make things a little bit better. And so I say, power to you. Go for it. No shame, no blame. Okay? So that's so on that. But now let's talk about your body for a moment.
Yeah.
It's important to break things out into small, manageable pieces, right? If you know, that's where IC gets overwhelming. It's like, can I please just do one thing that will make me better? What's the one thing that will make this go away? What's the one thing that I can do that will fix this all? For God's sake, please, God, fix this all, right? But pelvic pain doesn't work that way. There are different elements to pelvic pain. It's like, I'm sorry, God, I'm saying the word fire a lot, but it's real. It's like fighting different ground fires. You know, we got to deal with the fire over here and the fire over here and the fire back there to get them all under control. And that's true with pelvic pain. So you might have some bladder irritation going on. You might have some muscle irritation going on. And then we've got the thing about the whole guys with testicular pain who've got hip problems. And so I think it's important to just make a little checklist of things that we can check off. What is the health of my bladder? What is the health of my muscles? What is the health of my joints? And are there any other, what is the state of my diet? What is the state of my stress level? Little pieces. I don't expect you to build a house in a day. I expect you to lay a brick a day. And if you can just every day try one new thing or work on one little thing, understand with time that house will be built, that whole healthy house you will be better for it. You will be better for it. Okay?
Yeah, one question. So I think that's right, because I've been thinking like, okay, I saw a pelvic therapist at Mayo a couple of years ago. I thought maybe I should call them. And then I know sometimes spine issues, even though I haven't had an injury back, but just trying to find people that are in touch enough with how those things interact with your pelvic area so that they can say, oh yeah, no, you're your spine looks good, etc. That kind of thing. Trying to find those right people.
Well, it's just, you're just like, I mean, and this is where it's hard because you feel like shit. I'm sorry for swearing, guys, but it's true. And it's hard to be an advocate for yourself when you feel so bad. You want somebody to come in and rescue you. We all do. It's very hard to be the person who's got to make the phone call, who's got to ask the question. If you think that your spine is part of the problem, tomorrow, your homework for tomorrow is call and make an appointment. I used to teach small business classes for the SBA, and there was a guy named Jack Canfield who was a motivational speaker, and he said, ask, action, satisfaction. You can't get satisfaction until you take action, but you can't take action until you ask the question. So for you to start getting answers, we've got to start asking the question. And so if you can, make an appointment with an orthopedic surgeon and say, hey, I'd like to know if my back might be contributing to some of my pelvic issues. Could you just take a look at it?
Yeah.
Okay. So for everybody watching, you're not going to get to the end of satisfaction until you start asking more questions, and then you take action on those. So you're going to call and make the appointment, and then even though you might be feeling bad that day, you're going to take that action and go to the appointment and say, you're going to walk in and say, I am a mystery to be solved. I have got pelvic pain and we really don't understand why. But here's what I know. What I know is that my muscles are tight and dysfunctional, and I've had a history of back issues. I would like you to just look at my back and just tell me if there's anything funky going on. And then at the same time, for the next day, Tuesday, your assignment is to call your physical therapist and make an appointment with your physical therapist then. Again, little steps every day, okay? You don't have to do them all in one day.
Yes. And you were so right when you said we so want someone to come in and rescue us. I was like, that is exactly my thought. I want to be rescued.
I do too. I do too. Listen, we've never in our nation's history been under the stress that we are under right now. We have got COVID, we have got fires, we have got politics run amok. There isn't a minute in our daily lives until that election that is not going to be stressful in some way. And this is when, the pressure, the people are playing with our minds, they're trying to make us afraid of stuff and here and that. And sometimes you just got to turn it all off, go get your favorite book, go sit out in the garden and just de-stress, and that's hard. I mean, I carry my iPad and my iPhone around with me all day, and that's really, I shouldn't do that right now. Okay. But now listen, I'm giving you a giant hug right now. Okay. Big giant hug from me. You are not in this alone. There are millions of men who have this. I commend you for telling your story. I commend you for coming on and letting the people listening to this understand what life is like for a man with pelvic pain. You face the same challenges that we face in many respects, but you also have your own unique challenges because, and again, for the women watching this, you got to understand, men are taught when they're young that it's their job to fix it. It is your job to fix whatever the hell's going on. But when you can't fix it, it becomes a stress. It's like, what's wrong with me? I'm not a man. I can't fix my own life. Am I not a good man? Am I not a strong man? And that's unfair programming. You are hurt. You are injured. You didn't ask for this to happen. Right?
Right.
And yes. And there is no shame here. There is no blame here. And it's hard and it's humbling to have to be the person to ask for help. But you know what? That's the gift of humanity, is we love helping each other. And when you're through this, I'm going to challenge you to come back to me, and we're going to look at our men's resources and try to make it better. Okay?
Mm-hmm.
When we get, so, and I don't want you to think doom and gloom here. You got to have positivity in your daily life. I need you to laugh every day, right?
Okay.
Laughter helps modulate pain. So please get onto YouTube and watch funny videos. Or for me, I would love watching Jerry Lewis, Dean Martin movies, or, all those funny movies, the old Addams Family movies. Just let's bring some laughter and light into our lives and try to ease that burden. Okay. Do you feel a little bit better?
Yes, my own thoughts are my enemy. So hearing someone that, from an outside source is helpful to me. And what you said, there was a lot of good things there. So I'm very grateful.
Good. Well, I just understand, I've asked several doctors, why do our brains turn to the negative? Because if you listen to me, I'm an optimistic person. My magazine is called The Icy Optimist. I exude optimism every day. But I will tell you, in my brain, it's often negative. If you were to ask me, hey, Jill, let's drive up to Tahoe, I'd go, oh, hell no. No. There's a fire over there. That's my brain immediately goes to the negative, and I have to stop myself and stop myself from doing it. And I asked doctors, why? And they gave a biochemical reason. It's an energy. It's like a biochemical energy thing where a negative thought is easier on the brain to process than a positive thought. Something like that. I don't understand the mechanics, but it's a chemistry issue. So it's fascinating. So just, you got to do stop sign, deep breath, just try that. And I really think once we get the adrenaline levels down, you're going to start feeling better. I think you will.
Yeah, thank you. Because I know my anxiety is high, so I agree with you. Thank you so much.
All right. Well, listen, you know where to get me. You know where to get a hold of me if you need me. Okay.
Yes,
all right. Nice talking with you, Eric. Have a good one.
Thanks. Absolutely.
We'll have a better one. All right. Let's go to Carol. Are you there? Carol.
I'm here.
Hi, Carol. Can you turn your camera on?
I can't turn my camera on. I'm in pajamas.
Oh, here you go. Oh, okay. Okay, that's okay. Not a problem. Carol, how are you doing today? How is life for you today on Sunday, September 13th?
Well, I always listen in, Jill, but I listen in with my daughter, who is the one that suffers from the IC issues. So I always listen in and hope to learn and be educated so that I can help her, because she just suffers so desperately, and we still have not gotten to the bottom of whatever's going on with her, because she too, just like the gentleman just spoke, suffers from really bad anxiety, and a lot of her anxiety comes from what's going on with her bladder, as well as she started adult onset bedwetting, and it's all somehow really, really weighing on her anxiety. And we have not been able to figure out why the adult onset bedwetting, that she just has no idea why it's happening, as well as a lot of bladder pain. We had talked to you a few weeks back, and we stopped the birth control that they had put her on a couple of years ago. So we stopped the birth control. We started the aloe, which seemed to be helping quite a bit as far as the pain goes. But every now and then she still, has it's almost like something's not making her feel to urinate at night. So she sets a timer. She doesn't sleep well. She sets a timer to get up like 2-3 times a night just to go to the bathroom so she doesn't wet her bed. And
Right,
then even
right.
going 2 or 3 times a night, she still wets the bed.
So, incontinence is not a symptom of interstitial cystitis. Incontinence is a symptom of overactive bladder, and what that means is that the nerves, either the nerves in the pelvis have become compromised and kind of overactive, or there could be some potential abnormalities with her bladder itself. Does it have a super small capacity, or, you know, does she leak when she's standing, or does it only happen when she's lying down?
No, and she doesn't have any leakage, actually. She just goes, when she goes to sleep at night, and she doesn't, all of a sudden, she just doesn't feel herself needing to go to the bathroom. It's going to happen in the bed. So for her, it's really, really frustrating, because even though she gets up, like I said, 2, 3 times a night, sometimes, it doesn't happen every day, but maybe once a week it's happening. And the frustration is just so great. And she gets the intense pain in her bladder.
So her bladder does not go numb. What happens is her bladder does her bladder hurt at night even if she's not incontinent, or is the pain only associated with incontinence?
No, it hurts. It hurts during the day. And, sometimes she'll say, Mom, can you, the pain is so great, Mom, can you just rub my belly? And so, no, it bothers her quite a bit. And it's not just the incontinence, of course, she's sleeping and she doesn't feel it. What happens is she wakes up and she's totally frustrated. Oh my God, it's happened again.
Oh yeah.
And if it's happening to an adult, she's 24. So when it happens to an adult at 24, it's affecting her life, because, she's just so afraid of, what if I go somewhere? What if I, have a boyfriend? What in the world am I going to do now that I'm all of a sudden wetting my bed once a week? And so for her, it's just frustrating. But she does get, what happens if she has to go to the bathroom, she's got to get there immediately, or else she's going to wet herself. She cannot hold it for any period of time. It comes on like that, and within just a couple minutes, she's got to run to the bathroom. If she doesn't, she's just going to start wetting herself before she can make it to the bathroom.
What did the pelvic floor assessment show?
So we went, we did one session so far with the young lady for pelvic floor assessment.
Okay.
And we are scheduled to go back, but so I'm not sure quite.
Okay. So you've had an assessment. Do you know any of the results of that at all? Where muscles?
Well, I don't know if I'm trying to remember, Jill. But I know that, she did some pelvic exercises with her, and gave her some pelvic exercises to do when she's at home.
But we don't know if her muscles were weak, and if your muscles are super weak, that would certainly cause incontinence. Or
she didn't tell us that.
Okay, so well that's what you've got to do. That's your homework for this week. I mean, that is your guys' homework for this week. You've got to understand what the heck is going on with the muscles. If anything, maybe there's nothing going on, but it sounds like there might be something going on. I would want to know, are muscles tight?
How do you find out if it's like a nerve or something?
Well, they would do a test called a urodynamics test. And what that does is, what they do is they slowly fill the bladder with fluid, and they ask you, tell me when you first feel the need to pee. Tell me when you first, tell me when, I mean, it's a slow, gradual process where they're measuring what happens to your nervous system and what you're sensing as they fill your bladder. So it's tell me when you first feel the need to urinate. Then they're going to say, okay, they push through that a little bit. And then they're going to say, tell me when it's uncomfortable. And then they're going to push past that a little bit. And they're going to say, tell me when it's painful. And so what that does is that tests the responsiveness of the nerves in the bladder. And so, so I'm surprised that that has not been done yet. To me, that would be a reasonably important test to do since she's incontinent. I would want to know the muscles. I would want to know the nerves. And, you know, I'm always, now listen, I'm not a doctor. I can't give you medical advice. It's not my intention to give medical advice. My job here is just to talk about education and try to explore different areas here. I'm very intrigued by positional symptoms. The fact that she never feels that during the day. She only feels that when she's laying down to go to the bed. That she loses.
Right. Yeah, she never has incontinence during the day unless she can't get to the bathroom. She's running to the bathroom, and if she can't get there quick enough, then the bladder is so weak that, you know, she'll sometimes, it doesn't happen all the time.
I don't know if you can say, but I don't know if you can say the bladder's weak, hon. The bladder may not be weak at all. It may be that she has weak muscles, or she has an issue with nerves. What state do you live in?
We're in Florida.
Are you down south by Miami?
Well, we're in Palm Beach, if you're familiar with Palm Beach.
So there's
we're about an hour from Miami, but Miami's not far for us. If you know something good that you could tell us, because my poor kid is suffering, and we're just kind of at wit's end and don't really know what to do. Okay, so there is a new IC support group down in Miami that's run by a medical care provider, a physical therapist, and I have them on our website. Why don't you reach out to them? And and you know, this is not IC. IC does not do this. Really?
No, IC. If we could go, I've never been incontinent with IC. IC does not cause incontinence unless the pain is so severe that your body is just spontaneously, and that's only happened to me once in 27 years. And even then I could still hold it. I never lost it. I wanted to pee badly. I was stuck in traffic on the Golden Gate Bridge for an hour. Believe me, I wanted to pee. My body was saying, you're going to pee now. And I held on as hard as I could, and I didn't.
So like a week ago, she did a vaginal ultrasound.
Okay.
That was ordered. So she did the vaginal ultrasound, and the doctor called us and said everything looked good on the vaginal ultrasound.
Okay, well that's
didn't see anything.
Okay, but so that's good news. I mean, listen, you gotta have a different frame of mind when you're getting test results like that. Don't be disappointed. That's good news. If the ultrasound didn't find something funky, hallelujah, we're gonna move on, and we've got to explore other things. So don't be disappointed with that result. Be happy with that result.
Yeah, the urogynecologist that we have been seeing says she feels that it's the IC, but she has not been able to help us as far as the pain or as far as the sudden onset of bedwetting. We're just still kind of trying to seek answers. That's not IC. That's not. If you look at I challenge you to go over to the American Urology Association. You know what? Let's do it. Hold on. Let's do it. Maybe I'm wrong. Maybe, I mean, I like to think I have those guidelines pretty memorized, but let's wrong. Let me share my screen. All right. So can you see the owl? Yes. All right. And that's YouTube. All right. So let me open up a new window. Okay. And this is what we're going to do. We're going to go to auanet.org, which is the American Urology Association.
All right. So there we are. Now we're in the upper right-hand corner is a link. Whoops, hold on. Got to accept the privacy policy. Upper right-hand corner is a link that says guidelines. We're going to go click on that. Okay. And now we're on the guidelines page, and we need to search for the interstitial cystitis guideline. Okay. So you can see it popped right up. Obviously, I do this frequently. That's why it popped right up. All right. So here we are. There's the guidelines. So let's open them up. So this is published in 2011, amended in 2014. And I wish I could. So the guidelines are arranged in a series of statements. And let's just see. So those are the guideline summaries. So let's go here now. And let's see if we can find any reference to incontinence. Let's see here. Here we go. Here we go, right here. Pain, pressure, discomfort, and daytime urinary frequency, urgency due to pain, pressure, discomfort. No fear of bedwetting. No fear of wetting. Okay?
Wow. So we still haven't found what's the cause of what's happening to her.
Well, it's so now let's go back. Let's go back and let's get the guidelines for overactive bladder.
Could overactive bladder also make you have the pain right there in your bladder area?
Well,
You know, like during the day a lot, she complains, oh my goodness, she feels like she says, I feel like, Mom, like I have a bowling ball in my bladder.
Okay. Okay.
Pop.
So that is an absolutely huge symptom, because that is a symptom of pelvic congestion syndrome. You know, if you start,
she says she just feels like it's going to pop. You can even look at it and it just looks swollen.
Right.
And
so for those patients who, as you go through the day, it gets heavier and heavier and heavier until by the end of the day, you feel like you're carrying a painful bowling ball around in your pelvis. That's often blood accumulating in big, giant blood veins. That's pelvic congestion syndrome. That is what is associated with that bowling ball sensation.
Pelvic congestion syndrome.
Mm-hmm. And that's an important symptom. I mean, have you been to a gynecologist recently, or are you just doing the urologist?
Urogynecologist.
Mm.
Pelvic congestion syndrome.
I mean,
I have to write that down.
You know, so getting back to your symptom, your question, and that is, do overactive bladder patients normally have pain? The answer is not usually. They just have frequency and urgency incontinence. You know, so I mean, to me, it just sounds like they've missed something very logical here, some sort of other structural injury in your pelvis.
Well, something's definitely going on, because we even did blood work. We did blood work, say, a month ago, and her ferritin level was, I think, 11. And then we did it a month later, and the ferritin level was 7. Which the doctor said to us, I don't know a lot about this stuff. That's a lot. But the total iron was good, but the ferritin just continues to get lower.
Right.
She said, Carol, that's an indication to me that maybe there's like some bleeding or something going on.
Mm-hmm.
But,
So look at the screen. Look at what I just put up. Okay, so now we're on the overactive bladder diagnostic guidelines. Okay.
Okay.
And right down at the bottom, urgency urinary incontinence is defined as the involuntary leakage of urine associated with a sudden compelling desire to void. Incontinence episodes can be measured reliably with a diary and the quantity of urine leakage. Okay. However, in patients with mixed urinary incontinence, both stress and urgency. Okay. Well, anyway, there you go. This is where we find incontinence, is in patients with overactive bladder or something else that could be traumatizing thing. So here it says here, the clinical presentation. See, look, the clinical presentation of IC and bladder pain shares the same urinary frequency urgency with or without urgency and incontinence. Well, see, and this contradicts what I just said. Hold on. Okay, that's confusing. That's confusing. All I'm going to say here is that we don't see incontinence, involuntary incontinence in the typical IC patient. We don't.
Okay.
We just don't. We see that in overactive bladder. The fact that she has pain with that is confusing. And we have to try to figure out where that pain is coming from. Is it coming from her bladder? Is it coming from her pelvic floor? Is it coming from a nerve? Could she, I mean, she's 24. When did this start for her?
Maybe about 2 years ago.
Okay, and what was happening 2 years ago?
She, as far as what was going on in her life.
Well, just was there any, did she associate any event with the onset of this?
You know how you look back at things, and she was at that time in a bad relationship. I remember the first time it happened. She was coming home. She was running in. Oh my God, I got to get to the bathroom. I got to get to the bathroom. But before she could get to the bathroom, it already happened. So that was the first time that it happened, and that was like 2 years ago. And since that 2 years ago, that it just keeps getting worse as we go. And we've just been trying to find out, what's going on and why. But what's happening is she's a small person, but it seems like she's gaining weight right in her. So she went from having a nice flat stomach to now all of a sudden she's got a pouch there and having all of the pelvic pain and the urinary issues with bed. Well,
I think that if I were in your shoes as the mother of this child, I would be really trying to understand anatomy and asking doctors to study her anatomy more clearly. I would want to know what's going on with her pelvic floor. I would want to know what's going on with the nerves. I would want somebody to look and see if she has pelvic congestion syndrome or any other sort of reproductive issue that might be going on, like a fibroid tumor pushing on her bladder or something like that.
And now, would a fibroid tumor, would that have shown up in the vaginal ultrasound?
I would think it would have, but I think that's an important question for the doctor to answer. Okay.
I got you.
I'm so sorry.
Right.
Please give her a hug for me and tell her that, and I know I've talked to her on the phone. I've talked to both of you on the phone, right? I want you to look her in the eye and I want you to just say to her, this is not your fault. Don't beat yourself up. You're hurt.
Yeah, that's the
You're
thing
hurt.
she does,
I know, but there's nothing.
Anxiety's through the roof with this thing.
And so getting good anxiety management skills for both of you is important. You've got take a class. You can take a class online, whatever. You both got to build your skills here because God didn't give you the skills to deal with. This is new, and you got to go learn some anxiety management skills. But ultimately, in the end, something changed 2 years ago. And it is the job of your doctors to study her body to try to figure out what could have changed. And she's got to also try to be as you know, it's important that she go back into her mind 2 years ago, months leading up to this, to really think about, did she fall, abused in some way? What did anything funky happen? Did she eat something that gave her Montezuma's revenge? Something. Try to recreate that history a little bit so the doctor really has a clear idea of kind of the setting and the influences that might have contributed to this starting for her. Okay.
So in this situation, do you still think it would be a urogynecologist or just a urologist?
Well, I mean, I would be getting second opinions. I mean, if they haven't even mentioned overactive bladder,
No.
or doing a urodynamics, I think getting a second opinion would be reasonable.
Okay.
Incontinence is not a symptom of IC. Period. You know, it's not.
Okay.
Okay.
And the bowling ball feeling
The
is
bowling
not
ball
a symptom either.
No, but you know, it's funny because I've had patients over the years, you know, tell me that they feel like they're carrying a bowling ball around, and we just thought it was. And in fact, I asked several doctors about it, and they were just saying, "Well, it's inflammation, yada yada." And then I don't know, last year or something, I was working with a patient with pelvic congestion syndrome, and it really intrigued me. And so we just started diving into that a little bit more. And the classic symptom of pelvic congestion syndrome, I did an article on it in our magazine a couple of magazines ago, is that feeling pressure and heaviness as the day goes on. So, and the cool thing about pelvic congestion syndrome is it's very easily treated. It's very easily treated. So
Okay.
we've got stuff to rule out here. Okay. Keep in touch and let me know. And please give her a big giant hug for me. If she's there right now, if she's there right now, honey, you're not alone, and we're here for you, and we care about you very, very much. Okay. And don't beat yourself up. It's not your fault. Right?
Thank you, Jill.
Okay.
Thank you very much.
Okay, you're welcome. Bye-bye now. You know,
Bye-bye.
to the people who are watching this, I mean, that's just the perfect case here. You know, interstitial cystitis is a grab bag diagnosis. And years ago, we had a doctor say that, and we were completely outraged because we thought he was minimizing the IC community. And now we know he was pretty much right. That anytime a doctor can't necessarily understand what the hell is going on with you, and you've got pelvic symptoms, the odds are at some point in time, they're going to float out the word IC. And you're going to latch onto that and go, "Ooh, really?" And then you're going to come onto the internet and you're going to start reading about it. And then you're going to go, "Oh, okay." And then you're going to try stuff, and it might not work for you. And you might not be diet intolerant, and yada, yada, yada. We no longer think of IC as an incurable bladder disease, guys. We don't. It is a pelvic pain syndrome. Why? Because there are structures outside of the bladder that can change bladder behavior. Period. So we know that if your muscles are tight, your bladder's not going to get good blood flow, and it's going to compromise nerves, and it's going to mess your bladder up. We have a ton of tailbone injuries. I was just working with somebody again yesterday, another broken tailbone thing. That's so fascinating to me. But Carol and her daughter's case is so, it's an example of a mystery that is going to take work and consultation with doctors to figure out what the hell happened 2 years ago that has made her incontinent. Could she have developed a problem down at L4 or L5 that might be pressing on a nerve and doing something? I don't know, but I would want to know, right? Could she have a fibroid tumor? Maybe, but they did the ultrasound, so they didn't see anything. And at some point in time, you have to understand that your case is going to potentially out-challenge the skills of your local doctors. You're going to need to go potentially see a better, more experienced pelvic pain doctor. Okay? And so those are the cases that are extra frustrating. It's extra frustrating to me that somebody said she's got IC when there's no mention of incontinence in the IC guidelines. And we have to instead look at muscles and nerves also. And the confusing factor is, why the hell does she have pain? And the pain could be something outside of the bladder, like pelvic congestion syndrome. So they've got a lot of work to do to try to figure out what the heck's going on there. You know, I don't like to contradict a doctor. It's not in my position. It's not my place to get in between you and your doctor in any way, shape, or form. I want to get you back to your doctor with the right questions. That's, you know, that's just what I try to do. But I hate to disagree so aggressively with that, but it's not me disagreeing. It's the American Urology Association disagreeing. So, all right. Let's go to Donna. Hello, my friend Donna. How are you?
Hey, sweetheart. How are you?
I am.
How are you?
Well, I'm stressed. If
Oh,
you could
yeah.
look out my window, it's still smoky. And it's been a long ass week. And excuse me for
Oh,
swearing,
baby.
folks, but for everybody
I know,
watching
but you
this,
need to. You need to.
there are moments when you have got to.
Got to do it.
So I
Yeah,
wasn't sure I
I
was going to be able to do this today, but we made it happen. So
I know. I told Mark, I said, he said, are you going to have the meeting? And I said, you know what? I don't know. I said, what's going on with Jill? Who knows if the meeting is going to happen? I said, if it does, oh my goodness, then there must be a major breakthrough. But I just wanted to say to YouTube and Facebook, I know that things are going on. And as Jill has already said, this is IC Awareness Month. And I know we are in extraordinary times. And Jill has already said that. And I know I'm on YouTube more than I am on Facebook. And even today when I was on YouTube, and I'm going to go back to YouTube, I was really trying to be supportive of my YouTube brothers and sisters. I don't know all the answers. I'm learning from Jill. I don't know all the answers. And I tell you something, I said to Jill, you know, for the fact that she's not, because of the circumstances that she's in, she's not able to be with us as she normally would be. And so I think, my IC brothers and sisters, it's incumbent upon us to step outside the box. Since she's not going to be here, we relish the fact when she is, and we want to take so much advantage of that when she is. But I tell you, there's so much information on the IC network. The website, there's so many videos that Jill has out that talks about a lot of things that we're talking about right now. And I know that there are so many things that are going on with us that we feel like, oh my goodness, it's just us, it's just me, and that's all there is. And nobody else could be going through that same thing but me. I'm telling you guys, Jill has so much content out there. And that's what I used when I was diagnosed with IC. I used her content. I did go to the ACA, and then I came back to the ICN because she had videos, and I'm a visual learner, and I could sit there and look at her, and I, you know, you type it in and she would talk about all these different things. And I thought, wow. I mean, I know more now than I've ever known, but at that time I didn't know. And I thought, oh my God, she's got all this stuff. I didn't even know who she was. I was like, oh my gosh, she's got all this stuff. And my husband, we were together watching all these videos. And I'm telling you, if we just tap into those resources, if we just do that, go to the ICN network, look at all the content, spend some time there. I know that we can find some of the answers that we've been looking for. One thing that Jill hasn't done in a while, and it could be me, guys, and you tell me, or you tell Jill, the one thing she hasn't done is gone over all the 5.
The subtype.
Yes, she hasn't done that in a while. And I'm glad she hasn't, because she's done that so many times. And I think to myself, as we're talking about, I think by this time, our community, and I'm not talking about the new ones, but some of us old men and women who are out there, we should know those 5 subtypes. And to get in touch with those 5 subtypes are so important. Let me tell you, Eric, Andrea, and I'm only, because these are, and then Jessica and Sarah and Nicole and Linnea, I have decided to take Jill's advice and revisit my IC. I've had IC for now almost 5 years. And in some ways I've got better and in some ways I haven't. And so when Jill said, sometimes you just gotta pull back and revisit the whole doggone thing. And I thought, you know what? That's exactly right. So I did.
Yeah.
I went to my doctors and I revisited the whole thing. I said, don't even talk to me about IC. We already know that. That's a given.
Yeah.
Let's do some new stuff and see what we can come up with, because there could have been, like Jill said, even with our Carol, who we were talking to before, just a few minutes ago with her daughter, there could be some things that we just missed, that we just didn't get.
Yeah.
And Jill, I want to ask you a question since we're talking about this. Isn't it the urologist? Aren't the urologists supposed to know what's in those guidelines?
Well, now, isn't that?
And I don't mean to be condescending to the urologist. I'm not. That's not my goal here. What I'm saying is that I took all my guidelines. I went into the ICN network and I put it off. I went crazy and I took all this stuff to my urologist, and he looked at it. I mean, he treated me, but he looked at it as though he didn't know that was a part of it. I'm thinking, now as time has gone on, I'm thinking, are they supposed to know what's in their guidelines? I mean, hello, that's the urologist guidelines. Aren't you supposed to at least, at the bare minimum, keep up with your own guidelines?
I know it's I always know when I'm working with a patient who has a doctor that's uninformed when the doctor says DMSO and Elmeron. I always know that. And I remember, at some point in time having a discussion with the top doctors, and I was at an AUA meeting where it was like, how do we get these guidelines down to the local doctors? And it's hard. How do we get the pain guidelines down to the local doctors who are actually creating it? It represents the ultimate challenge in medicine is getting knowledge levels up, and also understanding too that medical schools teach differently. It's based upon the beliefs of the instructors. Some doctors believe that IC is real. Some doctors believe that it's not. And there's this whole level of information / misinformation / opinion that muddies the water. And then also understand too that IC is really dynamic right now. I mean, the fact that we're throwing out glomerations as a finding in the bladder wall is everything.
Mm-hmm.
And
the fact that you're talking about Hunter's lesions being in a separate
disease now, right?
That's
that's huge. So everything's changing. That's my job. My job is to show you how things are changing. So anyway, well, Donna, thank you for your good words and thank you so much. I really appreciate it. It's always good to see you. I love my IC sisters and brothers.
And you know what, Jill, and I love you for just taking the time to talk to me, because you know what? It's not that I don't have pain. I do. It's like today, I was in pain. And you know what I did? Honestly, to God, I don't cry a lot. And you know what I decided to do? Honestly, I cried. I just sat down and I cried. I just cried and boo-hooed and cried. And I'm going to tell you something. I felt so much better after.
Oh, yeah. Yeah.
Because maybe it was just a lot of tension that had been built up. All of you, Jill and Andrea and Eric and Linnea and all of you, maybe that's what it was. My husband came in, he goes, "What's the matter?" And I said, "I just needed to cry." He goes, "Are you okay?" And I go, "It's not about being okay. It's just about I just needed to cry."
Yeah.
And I did. And I felt so much better. And I know Jill has her way in terms of getting rid of the stress, and it's such a good thing to do that. But also sometimes you just need to cry. Sometimes
you
need to give yourself
I do. I do.
Just do it and forget about it. And who cares? Just let it out. And
right. I mean, you guys, again, I will tell you when I work with patients that some of you are spinning in a tight circle. You cannot stop yourself. You are just stuck. And trying to just stop the chaos for a moment and stopping the anxiety and stopping the tears and just saying, okay, hold on, stop, deep breath in. I do that. I did that with a doctor who called me. It's like I had to stop him. Deep breath in and out. Let's get through this. And then picking kind of small pieces and trying to work on those together and having a very healthy expression. Let it out, it will consume you. You have to have releasing your stress. And there are moments I cry. My mom cried a little bit this morning. I was trying to figure out why. She wouldn't tell me. You know, I mean, it is what it is. And
Yes.
Amen.
try
Yeah.
to let it out. Okay, listen.
Yes.
I'm going to go to Evie next, but I need to go use the restroom real quick. Okay, so quick bio break. Be right back.
Donna, can you hear me?
Yeah, baby. What you need, Eric? I'm here, sweetheart.
I
know.
I just
I had to
wanted
take
to
a drink,
say,
you know?
was going. I wanted to say thank you so much for and love what you have to say, and I just think you're a terribly beautiful person. So I just wanted to say thank you.
Oh. I don't have all the answers, sweetheart, but I tell you, when I was with IC, and I'm in Stafford, Virginia, which is a small city in Virginia. My husband's retired military, and that's why we're here. Diagnosed. I was the one that, along with my gynecologist, we were trying to figure out what the heck could be going on, and we could not figure it out. It just happened. And I never had a urinary tract infection. You know, we went through that whole, I know all of you know that when you go to the doctor, they do the urine analysis and it comes up negative. It had done that a gazillion times. And I know I'm exaggerating, but you know what I mean. Every time you go to the doctor, they want to do a urine analysis. And it kept coming up negative. And, you know, I was further and further in pain, you know, and finally, you know, we were trying to figure out what the heck is going on. And so I started doing research and looking WebMD and trying to figure out what's going on. And in the meantime, my gynecologist was doing the same thing. And so she called me and she said, hey, you know, I was really worried about you. And she said, you know, it really bothered me. You were in a lot of pain when you were here. And, you know, and I said, you know, I've been doing some research too. And we finally said IC at the same time. Because that, like Jill said, it's a grab bag. I'm saying it's just like, oh my gosh, you know what I mean? That when you can't figure it out, then guess what? It's IC. And so we've been going through that. I can pretty much, I'm not saying I can eat every spicy food. I'm saying that I can pretty much eat what I want now. However, it's gone to having vulvodynia where it's not my bladder. I feel everything in the vaginal area, you know. It's just like, oh my God, we've gone from one thing to another. So it is a revisiting of things, just trying to find out what's going on. I've been to my neurologist. We did MRIs on everything. You know, everything seems to be fine, and you know, it's just like, well, what else is there? And I gotta just to share with you, you know, and not to bore you, but I've got an appointment with my family practice doctor next week to do the blood work. Because I'm thinking, well, could I be deficient in vitamins? Could there be something else that could be going on? So, you know, I'm trying to revisit things and not just diagnosis to see what could be going on. Oh. So you guys, you know, hey, thank you, Eric, for being so wonderful and caring, and all of you. I love you all. Trust me when I tell you, I do. Linnea and Andrea and Eric, thank you for sharing, because you're a man, and I'm telling you, just to hear that from you, you know, I think about, okay, just between all of us, I think about my husband. I'm thinking, I wonder the next time he says, you know, I have a urinary problem, or I'm thinking, you know, and I go, you know what? Hey, I see men who are out there talking about this, you know.
Absolutely. Absolutely.
It may not be just what the doctors just think it is. It could be something more. So, Eric, please continue to keep up with us, because I am so riveted on you when you start talking about yourself, you know, and it's just, please don't stop doing it. Please
Thank you, Donna. Thank you, Donna. All right. Okay. Thank you for filling in for me. I appreciate that. All right, Evie, how are you today, my friend?
Hi. Thank you so much for this forum. I really appreciate it.
You know, on a scale of 1 to 10, I'm about a 7, I would say right now. I think that's pretty good considering the circumstances that we're all in right now.
very good considering the circumstances you're living under right now.
Yes.
Everybody's living under.
Yes, exactly. How are you? How is your IC?
Well, it's just recently been flaring again pretty bad. And so I started researching again, like Donna, for many, many years. And initially, they kept saying it was UTI. I did 1,000 UAs and they were negative. And I kept telling them it's going to be negative, and so finally I had a doctor who diagnosed me with IC. But I live in Riverton, Wyoming, where there's 5 other people here.
Yeah.
And only a couple doctors.
Yeah.
And only one that knows anything.
Yeah.
And
Yeah.
so it's really, really difficult to find a doctor that has a clue. And so in the beginning, I did the installations, the lidocaine installations, and they only lasted maybe an hour or two. They took some pain away, but then it came right back.
Okay. Hey, can I just stop you for a moment? I need you to move your camera because I've got a bright light shining at me. There you go. That's way better. Thank you. Okay, so they said they wanted you to do installations, and did they help?
So I did that years ago, and they would help for maybe a couple of hours, and then it would wear off and it would come back again.
Okay.
I tried Elmeron. I tried a few different antidepressants. Nothing really helped. The only thing that I finally found that seemed to help was when I totally changed my diet. I went on this ideal protein diet. I don't know if you've heard of that.
Mm-mm.
But then my IC went away for many years.
Ooh,
and
nice.
So I attributed it to that. But I can't say for sure that that's what it was. I also quit drinking alcohol years ago, and that seemed to help. But just recently I started a new job. And so I think maybe the stress of that has flared it again.
Well, tell us so tell us about the flare. What are your symptoms now? What are you struggling with?
So I have, the bladder pain.
Okay.
Just a constant bladder pain, and then the low back. And then it also radiates into my hips, and sometimes down my legs as well. And just like a real a bloating and a fullness. And as I heard you talking to Carol, I think it was Carol, I began to wonder if I had never heard of pelvic congestion syndrome. And I started wondering if maybe I have that, because I do have that fullness. As the day goes on, it gets worse.
Well, okay. So the pain shooting down your legs and all that's muscle. That's not bladder. The bladder does not cause pain to shoot down your legs. And how old are you now?
I'm 49.
Okay, and this all began in your 20s?
Well, so I wonder, and I don't know if you have any information on this, but when I was a kid, I remember having bladder pain at times after I had a bowel movement. I would have pain.
Okay.
And so I wonder if it goes back to then. And then in my 20s and 30s, I had, like painful sex, burning, and that kind of thing. And but I don't remember specifically, the bladder pain up until probably my 30s.
Okay. So let me stop you here. I want to go back to painful sex for a moment. Was sex always painful for you?
Not always. I would say probably for quite a few years, probably about 75% of the time it was.
Okay. Did you always dread going to your OBGYN for your annual because you knew when they put the speculum in, it would hurt?
Not necessarily. No, it didn't. That didn't cause me pain.
Do you have scoliosis?
No.
Okay.
No.
Were you in any accidents or any falls? Anything at all?
I mean, I've had numerous accidents. I was run over by a car when I was young, and then I've also, I'm a nurse, so I've been lifting patients over the years. I've hurt my back. I've had rollerblading accidents. Yeah, I've had lots of accidents.
Okay, so when we did now, and I apologize if this is a stereotype, so just bear with me here. Are you a horseback rider? You live in Wyoming. I'm just curious. Okay, that's all I needed to know. So that's the equivalent of bicycle riding, right? Or did you English or Western?
Western.
Okay. Okay, so just as when you're sitting on a bicycle seat, when you're sitting on a saddle, you are literally, you've got your legs open, you don't have a lot of padding, there's nothing underneath your labia that protects you. You know, like with our butt cheeks, we've got a layer of fat there. But when you're sitting on a bicycle and when you're sitting on a saddle, there's no extra padding. That saddle is literally pushing right up into your tender bits, right? I was a horseback rider too, back then. A little bit, not a lot. My sister was a good horseback rider. I was just the barn crew more than anything else. And did you ever get thrown from your horse? Land on your tailbone? Anything
Yeah.
else? Okay. Okay.
Yeah, quite a few times.
So what kind of job are you doing now?
So now I'm a nurse, and I'm a hospice nurse, and so
okay.
I've always, lifted patients, and I've hurt my back at work a number of times
Okay.
as well.
Have you had a pelvic?
I-
Have you had a pelvic floor assessment?
No.
I would bet you money. I would bet you money that going back to day one, you had a pelvic injury, and it probably started with one of your falls off of your horses.
Yeah.
You know.
Huh.
So as a nurse, let's talk about something here for a moment as a nurse. And so and I always love whipping this out. This is my favorite thing right now. I love my new demo. I love my pelvic cavity, right? And so if we look at the side, you can see directly as you are sitting, right, that you're literally sitting on your levator ani muscles. And if you were posting, did you post at all as when you were writing, or were you just sitting when you were?
Yeah, I did a little bit.
Yeah.
We mostly rode Western, but yeah, I did.
Right. Okay. So there are two fundamental reflexes in the pelvis, and you got to get this book. I'm just telling you right now.
No, can you tell me again the name of the book?
Breaking Through Chronic Pelvic Pain. Breaking Through Chronic Pelvic Pain.
Thank you.
So let's talk about these two reflexes, and you'll impress the heck out of, you'll probably scare the hell out of any doctors you see when you talk about this. So the viscerosomatic reflex, viscero means organ, so somata means muscle. So the viscerosomatic reflex is, can organs change muscle behavior? And the answer, of course, is yes. We have the guarding reflex. We know that muscles will get tight to protect you from pain, right? And you know, if you've worked with a man who is, I apologize, Eric, who have been taking a blow to the testicles, if you could pry your hands off their testicles, you would see it being pulled up into their pelvis. That's the guarding reflex. We all have the guarding reflex. So there's a group of patients whose symptoms began after a direct bladder wall trauma, and their muscles get tight to protect them. But our therapeutic priority for that patient is to calm and soothe the bladder. So the chemo patient. So you're working with patients in hospice who are dying of cancer. They've gone through extensive chemo. Some of them certainly would be having frequency, urgency, or radiation cystitis from radiation therapy. So we know the bladder directly can be injured. But there's another reflex that is equally important, maybe even more important, and it is called the somatovisceral reflex. And so that is, can muscles change organ behavior? And the answer is absolutely. And so these are the patients whose symptoms start after a muscle trauma of some type. So let's just say you fell off your, in fact, I wish Sue were here because this happened to Sue. She was also a horseback rider, and she had a really bad fall, terrible fall on one side. And I mean, life kind of goes on. You think it's a fall, maybe you have a bruise, life goes on. There's like no issue. But what we don't necessarily understand is the toll that takes on the physical health of the tissue. So when you suffer a compression injury, bam, you've compressed the muscles, you've compressed the blood vessels, and you've compressed the nerve. So anywhere that you've compressed the muscles, the muscles are now structurally injured. And there's a very good chance that they now have a trigger point in that spot. And most trigger points are silent. You don't know them. So it's like little trauma after little trauma after little trauma, trigger point here, you know. So before you know it, in your pelvis, you got a trigger point on the left side, trigger point on the right side, trigger point down at the bottom, all over the place, right? And then the consequence of those tight muscles is restricted blood flow. So now, in fact, you would find very interesting, there was an article on pelvic congestion syndrome that showed that patients with pelvic congestion syndrome only in that study got 9 units of blood instead of their normal 24 units of blood. So it's hard for an organ to be healthy if it is deprived of good blood flow. And then the other reality is when you suffer a compression injury, it damages nerves. It breaks the blood vessel, the little tiny blood vessel inside the nerve fiber that supports that nerve. That nerve needs blood supply to function. If it doesn't have blood supply, it cannot function. So that nerve gets damaged. It becomes a sick nerve. And so now we've got damaged blood vessels, and we've got damaged muscles, and we've got damaged nerves. And when you're young, you don't feel it. You don't feel the cumulative injuries until your late 20s, early 30s. And all of a sudden something happens and it's like, whoa, wait, whoa. So you go to the doctor and you go, hey, doc, I got frequency urgency. The doctor goes, yeah, you must have infection. They throw antibiotics at you. They don't work. The doctor goes, well, maybe you're having bladder spasm. To give you antispasmodics. They don't work. Then the doctor says, you know what? Maybe you got IC. Let's give you some bladder installations. Let's give you some DMSO. Elmerine. They don't work. Right? They don't work. For some of, not for everybody, but for a good portion of patients, they simply don't work. Why? Because the fundamental priority in the muscle injury patient is to restore blood flow. They could be on bladder treatments for decades and they will never get better. They will never get better until we restore blood flow. We've got to get those muscles healthy. So as we look at, and again, I talk about the concept of injury over and over and over again. We don't look at this as a disease process, except in patients with Hunner's lesions or chronic infection or something like that. We're really looking at the concept of injury. And Dr. Lavaz in the IC class at the AUA gave it a very specific sequence of events that begins with an injury. So when you were younger, you sustained some sort of injury that eventually healed and life went on, right? Life went on, but now you're hurt again. You're hurt again. And the question is, what is the injury? Is the injury that you're not using the restroom? And as many nurses do, when we did our professional survey, our number one profession that gets IC is nurses.
Interesting.
And so when I work with nurses, it's like, number one, you guys have your drink routine. And the nurses at any given station often share whatever Crystal Light or whatever it is. I once worked with a nurse who hadn't drunk water in 20 years. She was just drinking Crystal Light with her friends, her colleagues at work. So, and then the other thing is now that you're working again and you're lifting patients, you're working with muscles again. And the reality is that the original muscle injury might be better, but it could still be there. You could still have trigger points. You could still have something going on with your muscles. And your history as a horseback rider supports this foundation perfectly. So let me tell you about Sue for a moment. Sue over on Facebook, and she's been here many times, so we don't have a problem telling her story. She was diagnosed with IC. She spent 20 years doing bladder therapies. 20 years. Nothing worked. I mean, her symptoms might have been a little bit better, but she certainly didn't get to the point where she was symptom-free. And in her case, when she tried physical therapy, it always hurt on one side, like badly. It's like, Jill, whenever I do it, it hurts always at the spot. And it's like, okay, we need to figure out what this spot is, because that's not normal. It's not normal for there to be one consistent spot that always hurts in pelvic floor dysfunction. Usually the muscles release. Muscles respond beautifully to muscle therapy. I mean, you know that muscles, when you work with them, are incredibly responsive. And in her case, they weren't. So finally, she went to a specialist, and finally they did some imagery. And you know what it was? She's got this giant mass of scar tissue on the left side of her pelvic floor, interwoven through her pelvic floor. And it was exactly the space that she fell off the horse. Exactly the location. So imagine here, she's had scar tissue in her pelvic floor for 25 years. She spent 20 years doing bladder therapy that was pointless, because in the end, what it came back to was that original structural physical injury. And now she's, I haven't talked to her recently, but they're going to try to remove it, but it's going to be very tricky surgery when they do that. So you need a pelvic floor assessment.
And I'm wondering, can those two things cross over at all, the interstitial cystitis and like if you have, a musculoskeletal problem? Because I do notice that, there are certain things, and I've just recently realized that the powdered drinks, as you're mentioning, the Crystal Light bothers me. Wine, alcohol, apples, certain citrus foods. And also I've just noticed that the vitamin B, the B complex is bothering me. So there are certain things that bother me. Can it be both of those things?
Well, okay. Well, number one, it could be, the other thing that could be triggering your symptoms now is perimenopause.
Mm-hmm.
Right? Are you still are you still having periods?
I am, but they're changing. They're only like 1 or 2 days now, and they're getting light. So, and I'm having symptoms, perimenopause symptoms.
Right. Okay. And so that nice thick mucosal barrier in your urethra and in your bladder relies on estrogen. And so as your estrogen levels drop, the ability of that skin to defend itself is now compromised. And so that's not a disease process, that's getting older. And so if your vulva is dry and your vagina is dry, then you have to assume so is your urethra and so is your bladder. And that may be why you're struggling with the diet sensitivity right now. That makes as much sense, but we won't know. We're guessing. I think there's no doubt that if you're having perimenopause symptoms, you're going to notice changes. And that diet sensitivity is going to be an issue. And it would be reasonable for you to be doing a chondroitin-based product that might give your bladder a little bit of an extra coating, combined, more importantly, with perhaps a topical estrogen that will help your body produce more mucus. So that would help us with the bladder symptoms. But what we don't know is, do you have legacy muscle symptoms? And that's why having that pelvic floor assessment is going to be fascinating for you. Absolutely fascinating. And I hope they're fine, but they might not be.
Who would you suggest going to? Just a gynecologist for that? Okay.
Yeah. A gynecologist should have no problems looking at your skin. You need to do some research on the genitourinary syndrome of menopause, GSM. Look at the symptoms, see if you're starting to show the symptoms. One of the symptoms of GSM, so like it started for me in my 40s, is I felt like I was milking my bladder, that I would pee and then I would stop. And then I would pee and then I would stop. And I was like, am I done? I think I'm done. And then you stand up and you go, nope, not done. You sit down, another drop. And that is a classic GSM symptom, that the loss of estrogen is now weakened some muscles. At least that's the way my gynecologist explained it to me. So this might be the right time, this might be the time where your body's just saying, hey, I could use a little bit more estrogen here, maybe to help me. And then you've got to really just think about the safety and topical. You should know that topical estrogen products are considered to be remarkably safe now, that the old fear from 10 years ago is pretty much abated now, but oral estrogen certainly has some issues, and you've got to be really careful with that. Yeah.
Okay.
Okay.
Yeah, it's interesting though too when you were talking about the musculoskeletal issues. I also noticed when I go to the chiropractor and have my low back adjusted, it does also alleviate some of the symptoms of my bladder pain and IC. So I think that there is a connection there. Yes.
There you go. There you go. I mean, you're just checking the boxes here. You're checking the boxes. So a likely scenario is that you suffered a pelvic floor injury at some point in time when you were horseback riding and fell. It restricted blood flow. Your bladder wall started having issues. You had frequency urgency, and then thankfully things healed. Thanks. And you've been years without symptoms, but now, interestingly, you are just showing your signs of perimenopause. So we're going to see issues with tissue. Plus, you've started a new job where you're lifting. So you could have also tweaked your pelvic floor. So I think that those are the two most likely suspects here.
Okay.
Okay?
Great. Awesome. Thank you so much.
All right, hon. Well, again, those are just ideas. It'll be interesting to see what your doctor has to say too. Okay?
I'll get back with you. Thank you.
Okay. Nice talking to you.
Nice talking to you. I appreciate it.
You're very welcome. All right, Andrea, you laying there against your red pillow. How are you, dear? Listen, I'm going to try to unmute you. Wait. All right. How are you?
I've had a very rough week, I must
Uh-oh.
say, not had a lot of sleep.
Crap.
For some reason, I started to get pains all over again, and they're so debilitating.
Ugh.
And I am up all night, 8 times, 9 times, 10 times, voiding, barely anything, crouching down, feeling pain on my left side. And everything you just told Evie, I can see that is it. That is it. And do you know, I've been lying here with a hot water bottle between my legs because I'm in pain, and listening to everything, my body has just totally relaxed.
Yeah.
And my pain has gone.
Well, isn't that
I'm just-
interesting?
Yeah, my pain is gone. And for some reason, I haven't gotten up to go to the toilet once. And I am just so grateful to be, I know I have a gynecologist appointment on Wednesday for a pap smear.
Okay.
Which right now, I cannot let her do. I cannot, nothing can, I'm very, very sore, but I need to talk to her and I need to get a pelvic examination.
Well, okay. So, how old are you?
57.
And how long have you had symptoms?
The beginning of 2017.
Okay, so they started when you were, 54, and prior to that, did you have any history at all of any bladder issues?
No, but I must say that I have always been as a child, I was very anxious, and I used to wet my bed until I was 11 years old. And I was always an anxious person.
Okay, well,
And,
that's okay,
Right?
Well, yeah,
So
yeah.
I just think that maybe I've always been holding on to tight pelvic muscles.
Well, you won't know,
There are times.
You won't know until you have your muscles tested. And so
that's what I'm going to do on Wednesday.
Yeah, I don't, listen, you are an anatomical mystery to be solved. And your goal is to get your gynecologist to study your body. And we want to look at the quality and health of your skin. Let's see if there's signs of estrogen. We would ideally want to look.
Definitely.
Yeah, we would want to look at your muscles. Let's see what's going on with your muscles. You would certainly, at your age, want her to do a pap smear. I think it's important to rule stuff out. You gotta, but I don't believe in worrying about something. I think that if you have a worry or concern, let's act quickly and address it. And so, as a baseline screening, I think doing a pap smear would be reasonable. And I think doing a urine culture would be reasonable. Just dot our I's, cross our T's, make sure that nothing is missed there. And your ability to describe your symptoms is important. So I want to get to the pain for a moment.
Right.
Was the pain inside of your body or outside of your body on your skin?
Inside.
Okay.
Inside.
Is it in
Yeah.
your vagina or in your urethra or your bladder?
It's on the top of my pubic bone towards the left. I have this, it feels like if it's a string that's being pulled.
Okay, so then that's
from inside of me.
Okay, so that was my next question. Is it to the left or right of center? If it's to the left or right,
Yeah.
we're looking at muscles. We're not looking at the bladder. The bladder is centered. So now what we've got to do, we have to try.
What I was wondering, yeah, sorry, you go ahead.
Well, so how long have you had that pain? Is that pain been there for 2 years or is that new in this flare?
Anytime I get a flare, I get that pain. It's the same pain anytime I get a flare.
Okay, so
yeah.
Okay, so that's what you've got to focus on. That's the most important symptom that you tell. Does the pain radiate from the center all the way to your left hip bone? Or is it just like an inch or two to the left?
It's to the left, not to my hip bone. But on another level, I get pain above my right hip bone. I get this gentle pulsating, aching pain.
Do you ever have pain shooting down your leg, like sciatica?
I had sciatica when I was pregnant, which is 27 years ago.
Yeah, but so sciatica are tight. Sciatica is tight muscles that are compromising nerves, right?
Right.
So we know at some point in time you had a pelvic floor issue because you had sciatica.
Yeah.
When we think about the structures, so let's think about this for a moment. Okay, so hold on. We're going to do a pelvic cavity assembly. Okay, so hold on a sec. Let's just try to visualize these structures for a moment. Okay, so here is your pelvic cavity, right? And your pelvic cavity is hollow. So when we think about the left or the right, you can, uh-oh, my vulva just fell off. I love saying that. My vulva just fell off.
That's sometimes how I feel. It's coming out.
Okay. So the challenge with the pelvis, it is the core, it is the anchor of the human body. It has the largest bones in the body, the hip bones, because it carries the weight of your torso, right? So the pelvis is structural. It's what helps us stand upright. But the pelvis also deflects the stresses when we walk. So there's downward forces and upward forces, right, into this cavity. So in addition to the muscles necessary, the pelvic floor muscles that are necessary to help us walk and all that sort of stuff, we also have structures. So the first thing that we have is our uterus and our fallopian tubes. So oh wait, hold on. I can't put this on without my vulva. I think this is hysterical. Okay. So first thing we're going to do is we're going to put in the uterus. Okay. So hello, we're in. So now when we're thinking about the left side, so we know the uterus, we know the vagina is centered, but we do know that the ovary is on the left side. The fallopian tube is on the left side. So that's going to be something you're going to want your doctor to look at is there something functionally wrong there? Then, of course, we have to put the bladder in. So I got to put the bladder through the urethra, which is remarkably hard to do. Okay, so now the bladder, you can see, is in front of the uterus. And then, of course, we have bowel. So I got to get the, so here we go. I got to stick the bowel in through the hole and connect it. Is it connected? Okay, I have to connect the rectum. Okay. So anyway, so here we go. So now we have an extremely crowded pelvic category, a cavity.
Right.
And this is where visualizing your pain is incredibly important, because if it was your bladder pain is very centered.
Right.
If it's 2 inches to the left, then the odds are it might not be your bladder. The other thing that we have going on the lower left-hand side is your bowel. And I will tell you that for me, I have something that I call rectodynia. I mean, I'm a redhead with super sensitive skin. I'm IC subtype 5. There isn't a part of my body that isn't sensitive. And my rectum is a very, very sensitive. It doesn't like anything touching it, period. I can't walk around with things touching it. I have to deal with it.
Oh.
But during IBS attacks, the part for me that's the most painful, and thankfully those are controlled and I rarely have them, is that lower left-hand side. I call it a bend over and screamer. And that makes sense because that's where your bowel is. I mean, you can't walk. You're just sitting on the toilet or laying on the floor in the fetal position with a really bad bowel spasm. So to me, the most important thing that you said is that you have left and right side pain, which takes us back to instead the SI joints. So you've got, I don't know if you can see this. So here's one SI joint here. Here's the other SI joint here. And you'll see that they're an inch and a half to the left or right of center. And if this SI joint is dysfunctional, the muscles that normally hold it together become tight and painful, and that's what causes sciatica. So I think I'm glad that you're going to the gynecologist, because it's time for her to take a fresh look at your body, take a fresh look at your pelvic cavity, and say, okay, here's the one symptom that I've always had for every single flare. Pain on the left side. Can you please help me understand what that can be? And I don't know what it could be. It could be endometriosis, a little adhesion tissue on the left side. It could be maybe an ovary, or it could be a tight piriformis muscle. Okay.
Right. Okay. Because I can't even lie on my left side at night because I can feel the pain in my bladder. Yeah.
Well, okay, but you have to qualify that. If you had SI dysfunction, laying on that side is painful. And so
but it's painful in my bladder. It's painful to my bladder. That's it.
Does the pain go away when you pee? Or is the pain still there after you pee?
It can be, it goes away. It goes away when I pee. And if I go and lie back down, it's I just can't lie on my left side.
Well, you need to tell your doctor that. You need to tell your doctor that. We have to understand the mechanics of why that happens. I can't sleep on my left side because I dislocate my jaw if I do, because I have really weak, because I have TMJ, which is kind of part of this whole thing. So I don't know, hun. I would want your muscles looked at. I want somebody to focus on that left side. But the other reality here is, now that you've laid down and relaxed, your pain has gone away. That helps us point to the fact that maybe some of your pain's being driven by tight muscles. Maybe.
Yes. I am more sure of that now. I mean, I always thought that, but I was just lying here and listening to the YouTube, got up once and then heard Donna say go into the Zoom, And I thought, okay, well, let me click in. And I thought, well, let me just say it one more time, you know. And but I do feel as it is the muscle.
Good.
I do feel it's the muscle.
Well, listen,
Thank you.
if during her pelvic examination she touches a muscle and triggers pain, that is the hallelujah moment. That is exactly what we want.
Yes.
You're going to say, what are you touching? And that's
Yeah.
where we need to go. And you may have just had a long-term injury there for a long period of time. And so
Well,
it's
I'm a faller. I fall a lot. I used to fall a lot.
Well,
I was tripping, I was falling down steps, whatever. That was me.
okay.
You know,
Well, and
still
that's
do.
and that
Yeah.
the absolute risk factor in all of this is repetitive injury, repetitive recurring injury to the pelvis. So
I'm a faller.
okay.
Yeah.
Well,
Well, thank you, Jill. Thank you so much.
keep us posted.
You're
Let's see
like
how you do.
angels. Like
Thank
two
you.
angels you are, you and Donna.
Thank you. All right, hon. You keep in touch. Right
All right.
back to you.
Yes.
All right. Linnea. Hello, my dear. How are you?
Hi, I've been thinking of you. I'm okay.
Now, can I get you to turn around so the light's not coming in?
Is this better?
No. I just rotate can you rotate your chair? Yeah, there you go. That's way better.
Okay.
All right.
All right.
Thank you. It's been a journey. Again, I just want everybody to know at some point in time, understand that I may come and do a meeting and say, help me, where can I live?
Ann Arbor, Michigan. I went through 2 fires in San Diego County. I'm in Ann Arbor, Michigan now. I was stuck in Florida at the beginning of COVID. But I have a spare bedroom, but there's 3 of you, right?
There's 3 of us right now. Yeah.
I'm a specialist in elder care and dementia.
Oh, I was just talking with I hate to do this. I was talking with my mom last night because I'm very, very frustrated with family members who are not helping. And to be in the era of COVID and now in fires and having somebody who is literally 90 minutes away, not once ask how they can help, is very frustrating to me. It is hard. This is hard.
It hurts your feelings. It angers you and it frustrates you.
Oh, it does.
At the same time, right?
It does. And so she finally asked me, and I just said, we don't have to talk about this. She goes, no, I want to do it. And I just said, listen, I'm tired. And it would be nice to have some help. And
Anderson Cooper was parked out on my former street for 3 days because it's right near the Wild Animal Park.
Wow.
Down the hill in Rancho Bernardo. It jumped all the lanes of the I-15 freeway
right
near Lake Hodges and went into my former neighborhood. Was been with
right.
Because I had put on the reverse 911. The whole street was on fire. He was going this way. The fire trucks were going this way. And that was the second time that 04 it went right around in the circle at Poway. See, the sky was all red in Poway. And when you see the sky all red for hours, you don't know why. So I'm in Michigan.
All right. So I'm just warning everybody here, at some point in time, I may just say, we're getting in the car. We're going east. We're stopping in the We might. We might. Or I was talking with Donna earlier this week. It's like our fantasy, but I think it's more than a fantasy, is to have a safe place for us where we can support each other and be there for each other, and just life is rough right now. But how is your IC? How are you doing?
It's pretty good. When I adhere to, okay, so I have the coccyx injury. I have the multiple injuries.
Mm-hmm.
I have the history of irritable bowel, irritable bladder,
right,
and pelvic inflammatory disease in Japan, where they gave me the antibiotics before they tested the pathogen. So I have a snowball of different things.
Right.
But things are under control. But I just came on here to to publicly say thank you, because I don't know if you remember, it's like times are hard and I haven't been able to work. And you not only sent me these, but you sent me the book for my birthday. And I'm just so thankful. And I was like, I pray for you and I pray for everybody. And I just, there is a special star up in the heavens with your name.
Oh, thank you. Thank you. And for anybody watching, I still have about 75 old magazines that I'm happy to send to anybody, no charge. And so all you need to do is email me, icnetwork@mac.com, your mailing address. Some of you just email me, say, I like books, and you don't give me your address. And it's like, I can't send them. I need addresses, but I always, you know, I think that, oh, look, okay, so now the bladder fell open. I love this. This is going to be a comedy routine for me.
You have that. It really does help.
It does. It does, doesn't it? I'm so glad I got it. But anyway,
really cool app.
huh?
I wanted to show you. I think it's on my iPhone. I found this really cool app. Do I have it on my iPhone or just on the iPad I'm talking on?
Yeah, because we're starting to work on a new app now too. A new app that's going to come and do some things that haven't been done before.
And this app shows, I think it's for gynecologists to other gynecologists, but there's this, like, you can, like, next time I'm on.
Okay. Well, we should talk about it, because I already mapped out a flare app. I did that for years, where people could put in their symptoms, and then it would try to tell them what kind of flare they're having, and then it would give them a rescue plan. And we actually started building it, and then the builder quit. And then something else happened, and I just kind of dropped it. But so we have a flare app mapped out, and we also have a new flare product coming out that I can't say more about it, but it's a very exciting for people who are in intense flare, something that might help.
I tried aloe vera years ago, and that helped. And I found out that I'm allergic to the volatile oils in coffee and chocolate. My parents told me I was allergic to chocolate when I was a kid.
Oh, I'm allergic to chocolate.
I pee the bed. Now that's something totally different.
Yeah. Oh, and Carol, if you're still watching, Carol, with your daughter with incontinence. Hey, we didn't talk about that. Does she have any new food intolerances? Because sometimes adult onset sensitivities occur. And the fact that you just reminded me that you can have incontinence from an essential oil problem like chocolate. Chocolate destroys me. I cannot touch chocolate. I can do coffee, but I can't do chocolate.
I'll wake up in the night and I'm wet. My whole bladder and my urethra will just...
Oh my God.
No, they just won't even function.
Okay. Oh my God.
It's so allergic.
Carol, where are you, Carol?
She's on here. I don't see her on here.
She's not on.
People on Facebook hear us on Zoom at the
same
time?
Yeah. Facebook.
Oh my God. I always came on Zoom because I thought it wasn't so public.
Oh no, I say that. I say that at the beginning. I'm sorry, hon.
I just stoned it out.
Yeah, but most people leave, so.
It's okay.
Yeah. Okay. So anyway, Carol, if you're watching this, please remember that.
Right. My mom, I was allergic to strawberries and chocolate when I was a little kid, and then dust, pollen, and mold, and I grew out of the dust and the pollen mostly, and now I'm back. I'm a dust. Allergies can come and go. My mom got allergic to red things in her early 80s.
Yeah.
And strawberries, and you know, they figured out when I was a kid that I was allergic to red dye. I couldn't have orange pop or pistachio ice cream because it had red dye in it. My parents in the 60s figured this out.
Yeah, oh God, hold on a sec. Yeah, you're absolutely right. You are absolutely right. Okay, thank you. Oh my God, thank you for sharing that. I'm going to remember that and try to reach out to Carol again. All right, girl. Well, listen, thank you so much for your good words. I really, really, really appreciate it. And as somebody who's been through the fires, you know what our life is like, and it is rough right now. So
it's scary. It's scary. The firefighters that saved, partially saved, because it partially burnt my former house. They said there was a tornado.
oh yeah, yeah.
It makes it so muddy that it was evaporating the fire hose water.
Yeah. Yeah.
Anyway, you be well and safe. Goodbye, everybody.
All right. Thank you, hon. Okay. Jessica and Nicole are our last two. Jessica, are you there, or did we do you?
Yeah. Yeah, I'm the one that can never get my camera to work.
Okay. And I'm going to send you a ask to start the video link. Maybe that will work.
Yep.
Hey, oh my,
So,
you have IC
it's-
Awareness Month hair. It is
I do.
stunning.
Are silver.
Oh, you guys, she has the so you've colored your hair kind of a turquoise.
It's actually a wig.
It's a wig. Oh, I want that wig. I would totally wear it right now. Oh,
I got it from Amazon.
That is
But
beautiful. Well,
I was like, I'm gonna represent.
how are you? How is life? How is your IC?
It's the same. Basically, I have low vitamin D, high
Okay.
cholesterol, which I knew I have because I haven't been able to exercise at all.
Right.
And then I trying to think what else I've had to do. I got my MRIs approved through my insurance.
Okay.
It took a few steps to get that done, so now I gotta set that up to see what's going on with my back and my neck.
Okay.
So everything is kind of in a holding pattern until I can figure out if anything is attributed to my back.
Right.
Because
right.
it went out so badly.
Right. Right. But the point is, we were talking earlier about ask, action, satisfaction. So you are asking the question. You've already asked the question, and you're taking steps to take the action needed to really answer that question once and for all. You know, is it your back? Is it anything else? So good for you, hon. That's exactly what you've got to do, guys. This is a slog. It's like question, answer, question, answer. Okay, we got that rolled out. Good. Now we're going to come over here and we're going to do this one. Okay, got that rolled out. Okay, we're going to come up here and do that one. You just got to keep it up until you start finding answers. So good job.
With an MRI and pelvic congestion, is it hard for a radiologist to see that? Because someone had mentioned that most radiologists don't see that on an MRI.
It's a specialty. It's a specialty. If you pop me an email, I will send you the magazine with the article. Here, hold on a sec. Is it up there? Here it is. Oh no, it was last summer. It was last spring. So it was in our spring magazine.
Okay.
And so let's just see what okay, PCS treatment. Let's see, hold on. Advancements in medical technology have made finding and fixing pelvic congestion syndrome easier today than ever before once patients find the right doctor. Dr. Brooke Spencer, our medical director and CEO of Minimally Invasive Procedure Specialists in Denver, said interventional radiologists can help the best. So it's an interventional radiologist. Typically, once an interventional radiologist suspects PCS, he or she performs a venogram to take a look at the veins in the pelvis and determine whether they are functioning as they should. Spencer said that in looking for an interventional radiologist to treat it, patients should look for one that uses intravascular ultrasound to determine whether there is a vein issue. IVUS is a mini ultrasound probe attached to a specially designed catheter that they use to check veins. And she says, I would caution patients against going to anyone, she said, noting that patients should ask about the tools the doctor uses and how many of these procedures they perform annually. The website for the Society of Interventional Radiology, which is sirweb.org, SIRWEB.org, has a database of doctors searchable by location and specialty and is a great starting point.
Okay.
Yeah.
I'll definitely check that out.
Yeah. Yeah. Cool.
And I sent you a couple emails, but I don't know if you've gotten them.
What email address are you sending them to?
I'd have to check, but I'm pretty sure it was like ICN.
No.
I gotta look.
Yeah, it needs to be icnetwork@mac.com. And if you want to get my attention, do the subject title in capital letters and say, Jill, read me from chat. You know,
okay, yeah,
you gotta hit me up the side of my head to get an answer from me.
Okay.
I mean, I get so many emails that I just can't answer them all. I do my best, but
no, I get it. You're super busy.
yeah. And somebody was saying, I forget who it was, about on Facebook, and I'm not on Facebook at all, other than to do these. Facebook hurts me.
That was me, and it was just to say, like, you know, when it says add a donation,
yeah,
I can't find IC Network.
Well,
it only has interstitial cystitis awareness.
Well, the reason why is because we're not a typical nonprofit. When I started the IC Network 27 years ago, it was my doctoral dissertation. So I paid for everything for 5 years. And then finally, it grew so much. I ran out of money, and I wasn't working by then because I'd lost my job, obviously. We needed to create a legal structure because that was when it cost me $200 a month to be on the internet. You know, so I used all my savings, was living on credit cards. It was ridiculous. So we had a little powwow of our members, because we had a lot of members back then, and said, what do you want to do? And I did our nonprofit assessment, and there was no money. And I was a nonprofit fund development director while I was in grad school. There was zippo money for IC back then, nothing. And any money that was there, the ICA had. And so one of my other members, I got your email, Jill, read me from chat, or that was somebody. Anyway, one of my members said, you're an educator, be a health education company. And I went, oh, isn't that cool? And that's what we did. So we are a publishing education company that we give 95% away what we do for free, but about 5% we charge for. So people make donations to us all the time, but it's not tax deductible. So yeah. And I'm understand that when I started the IC Network, we were not welcomed. You know, I actually pitched the idea to the ICA and said, I will build you the first website on IC. And I got a lecture on knowing my place and what a stupid idea it was.
Wow.
Oh yeah. No. They were not nice at all. They were very, at that time, and granted, this was a long time ago. What she said is, well, if you do it, we will never, ever acknowledge your work. And to this day, 27 years later, they have only mentioned us once.
That is very stubborn.
So it has been a long slog to be where we are. I mean, we are the top, we're the top support group now, and I am the national support group leader. But we took a lot of heat early on. People were saying, well, she's a for-profit, she's profiting off of patients. And it's like, where? It's free. You know, like, where? Tell me where. It's free. We didn't have a store. We only had a store 15 years ago. And so I'm overly sensitive and cautious about people who say you're just living off of patients, because we're not. we're not. It's
Yeah,
95% of what we do is free. The support group meeting is free. Our phone time is free for the vast majority of patients. So anyway, that's just kind of to clarify that just a little bit. I hope that makes sense.
Gotcha.
Yeah.
No, it does, because I actually ran into the same problem because I don't get where I'm at with IC. I feel like it's kind of almost like an umbrella for what they don't know, kind of like they did with autism. If you weren't autistic but you had those characteristics, they do PDD NOS.
Right.
I mean, crazy.
Yeah.
So, I was in the embedded infection group, and I had mentioned something about IC, and man, an admin was like on top of that in 2 seconds. And they're like, we don't want to hear about IC. And I'm like, why are we competing? If anything, we should be sharing information with each other. This shouldn't be a fight. And
that, unfortunately, in the IC world, from then this goes well before I got involved. There was never a spirit of collaboration. It was always a spirit of competition. So by the time I came around in 1993, I just in my noble self thought, I can come in and make things better, and not having a clue that I would then threaten people with my ideas. And our dream has always been to bring, and for those who know, I'm the yes girl. If somebody has something they want to do for IC, I would never say know your place like I was treated.
Mm-hmm.
If somebody has a legitimate idea, they want to give it a shot, it's like, all right, let's talk about it. If I can help you, I can help you, because we got to get the next generation past me up to speed, right? And anybody who thinks they know it all is a fool. There are multiple perspectives involved, just like there are multiple doctors. We have to welcome people. And so if anybody out there, you have an idea about something you'd like to do with IC, call me. And 9 times out of 10, I will say, how can I help you? This is great. Nobody's ever done this before. Let's do it. The challenge with there's a historical challenge, though, with the bacterial community, because they've been around a long time. And I've been dealing with them from the old IC news group back when we started our website in 93 and 94. They come from an all or nothing perspective. It's like everybody has chronic embedded infection, or everybody has infection. And it's like, no. How do you explain the patient who gets IC while they're going through chemo? How do you get the patient who gets IC after they have a baby? What about the guy who was sliding on his socks and fell on his tailbone and that night had frequency urgency? Those are not infections. So my challenge is people who have come with all or nothing positions, because it's simply not true. There's diversity in this patient population, and that's our strength and that's our weakness. So that I go to Facebook and it breaks my heart what I see, but I literally can't answer everybody. I can't do it. It would make me crazy trying to do it. And so it's like, I just hope people are saying, come on over to the IC network, watch the 5 subtypes, call Jill, and I'd be happy to talk with them.
Oh, if we even mention IC network or IC at all,
oh yeah,
they literally threaten to kill us or kick us out.
Oh, I know. And that's the ultimate flaw. I have a master's degree in small group development. And when you in psychology, and the theory that I brought from that degree to the IC world is the least important opinion in the room is the leaders. The leader's job is to facilitate discussion. The leader's job is to not dominate the conversation and tell people my way is the right way. That's what a support group leader is supposed to do, is to facilitate. And that you don't see that in these groups, and people are being harmed. And also, just so you know, at the AUA this year, Dr. Curtis Nickel did an amazing lecture on the urinary biome and the dangers of long-term chronic antibiotic use. And
Mhm.
his lecture was seen by tens of thousands of urologists, and his position is that we're going to be treating infection with other bacteria. We don't want to keep destroying the biome. You're
Yeah.
creating dysbiosis. Dysbiosis creates the foundation for all sorts of cancers and all sorts of stuff like that. So again, I've got that summarized also in our magazine. So yeah, I just don't. I just can't do it.
Yeah, I just wish it was more inclusive. I know I was shocked today because I was pre-med. My dad's med, and I think it's Harley Street in England or something. But that professor doesn't even believe in the microgen test. You can come out negative, and I'll still give you antibacterial. And I was like, well, how can he decide what medication to give you if he doesn't know what bacterial infection you have?
Exactly. They don't believe in any testing. They're
It was insane to me.
they're
I was like, there's
guessing.
no way I would take anything without.
And that's called antibiotic stewardship. You know, we have such an overgrowth of drug-resistant infections right now for reasons just like that. People throwing antibiotics at viruses and fungus and things like that. And to not even do baseline testing is stunning to me. And they've got a reason, and they believe in that reason. But ultimately it's a guess. And the recommendation of long-term antibiotics, we don't understand the ramifications of what that does to the human body. What we do know in the AUA guidelines is they don't recommend long-term antibiotic therapy, period, because of the damage it does. And then that patient's going to have potentially other infections because of that, you know. So they might have C. diff. They're certainly going to have a problem with candida and stuff like that. So I don't know. I just can't.
I'm hoping my current doctors. I heard the other lady had an issue in West Palm, so I hope it's not my doctor, but mine seems pretty thorough. She's testing DHEA, Lyme disease.
Good.
CDOH. I don't know. There's like I was looking at it like I didn't even think to test these things. She's being so thorough.
Well, that's the thing is if you look at the European IC guidelines and the American IC guidelines, they both say rule out all sorts of different types of infections, including viruses, including funguses, but they don't talk about it in depth, and they should. They should. So anyway, well, you look great. You sound good.
You.
I think you're
trying to represent.
You are doing. I wish I had thought of that. I'm gonna look for that wig. You should send me a link to that wig because I would totally wear that. Okay. All right. Nice talking with you. And let's go to our last person, Nicole.
Hi.
Hello, Nicole. How are you?
Good.
Okay. Can you turn your camera on?
I'm trying.
There you go. Well, okay, maybe. I'm gonna. There you go. I'm sending you a link. Ask to start video. So Nicole,
I can just leave because I don't know. I'm just kind of stuck.
Oh no, you're fine. You're fine, hon. All I have to do is there you go. We've got Nicole and Jessica. I just need to mute you, and we are good. All right,
Okay.
Nicole, how are you today?
So I reached out. I was on the Facebook group.
Yes.
Because I'm the one from the back brace.
Yeah. Oh yeah, look at you.
Yeah. So I'm going to stand up just because it's a little easier for me. It doesn't go into my throat if I stand up.
Oh.
So I have to say, I have learned so much in the past few hours. And I think I'm very similar to Evie's story.
Okay.
So I can be a little more specific. So I have an old injury to my L5S1.
Okay.
I've known forever.
Yeah.
I've had since I was little.
Okay.
Gymnastics, volleyball, something happened when I was little, and it's always been there. I've had IC. I probably got diagnosed early 30s.
Okay.
And I'll be 48 next week.
Okay.
My cousin's also diagnosed, so I didn't know if that's like a genetic thing or can be a genetic thing?
Well, I see subtype 5 central sensitization can be genetic. My sister, my mother, we all have bladder sensitivity, but we also have very sensitive skin. We have, okay, so we've got drug sensitivity where normal doses of medications. We have food sensitivities where there's some foods that just don't work for us, not just our bladder, but our bodies in general, like chocolate. We have a, okay, and so we have a wicked sense of smell. We can smell things that other people can't smell, and smells drive us crazy sometimes.
Yeah.
Right?
Yeah.
We can be very chemically sensitive. And we can,
huge.
Okay, we can be visually sensitive, where if there's a funky pattern in a carpet or a wallpaper, we've got to close our eyes and turn away. And we can even be sound sensitive. We can even be sound sensitive, where certain sounds you just can't sleep. If there's a cat crying in pain, we'll never sleep through that. You have to get up and find the cat and fix the cat, right?
Right.
So central sensitization is an evolutionary priority. I am Norwegian and Swedish. And is your background, are you English or Irish or German or Swedish? Okay. So if we go back 5,000 years ago, what were our ancestors eating? The world's blandest diet. They didn't have a lot. They didn't have fruit. They didn't have a lot of fruit. They certainly didn't have oranges. They had berries. They might have had apples. They might have had some greens, but they were mostly eating meat, fish, right? And so we can make a couple of arguments here. Argument number one is that sensitivity is an evolutionary priority because they needed to figure out if the water was good or bad. Because we're the ones with the nose that can tell you if that food's bad, right? And so every tribe needed people who were sensitive to some degree. But also, if we look at what our ancestors were exposed to, so I come from northern Norway, northern Sweden. I mean, we're 95% of me. What were they eating? Fish, berries, and maybe deer. There was no coffee to be had in northern Norway 5,000 years ago. There was no citrus. And so the other argument that we can make is one of evolutionary adaptation. It takes 5,000 years for an evolutionary adaptation to occur. So, and we've only been exposed to chocolate for 1,000 years. Chocolate comes from Africa, right? So people from Africa, their bodies have been exposed to chocolate for a much longer period of time than mine. So my body does not have the defenses it needs to process chocolate and protect myself from the irritants of the chocolate. Just as somebody who grew up around the equator and they had a lot of fruit year round, they had a lot of acid. They had mangoes, they had papayas, they had all that stuff. So their bodies have been exposed to acids for tens of thousands of years. They've had plenty of time to build a strong bladder and a strong gut that could tolerate those acids. Whereas my ancestry has not had that same thing. And so I think the moral of this story is that sensitization is not a disease. We don't treat it like a disease. The odds are you've been sensitive your whole life. The odds are you probably couldn't use bubble bath because the bubble bath irritated your skin, right?
Correct.
Right.
Still can't.
Okay, me too. So that's not a disease. That's just how we're wired. We're more sensitive. And if we were in tribes, we'd be fine. But life in 2020 is filled with irritants. And it's hard when you're sensitive, it's hard to live and have a body that doesn't know how to process stuff and respond to stuff. Also, sensitization can happen after trauma. An injured nerve becomes a more sensitive nerve. That's why that person who broke their knee years ago, their knee aches when a storm's coming in because that injured nerve becomes a sensitive nerve. So you and I are also sisters. We are ancestral sisters, and we have that sensitivity. And it's our responsibility on a daily basis to protect our nervous system. We're not going to be drinking caffeine, which turns nerves on. Right? I mean, the last time I had caffeine accidentally, I was awake for 36 hours. It was bad. We already
I'm also gluten-free. So I went gluten-free like a year and a half ago, and that made a world of difference.
Yeah. I mean, it's so interesting that part of what we're dealing with is, in fact, our body struggling with modern day life, and the corporate industry that is deliberately doing things that they know will hurt us, hurt you and I more, because we have a more sensitive nervous system to begin with anyway. So there's no sense in your home. You don't use Febreze. You don't use Glade plugins. You don't use chemicals. You clean you clean your bathroom with half of a lemon or vinegar or something like that. And so now you have a back injury.
Yes.
And that,
yes.
and so we know it takes less stimulation to turn pain on for us, because our nerves are easier to turn on, and you feel the injuries more intensely, and so now that you're recovering from your back surgery, I'm sure that a lot of your pain is up, right? Kind of throughout your whole body, is it?
I didn't have surgery, so I fell.
Okay.
And I fractured my L1.
Okay.
And T12, and they think T9. So we're having some interesting people, the way the radiologists are interpreting results.
Okay.
So I went from X-rays to MRIs. Now I've had CTs.
Okay.
So they're trying to get just that clearance on the T9, but they know the L1 and T12.
So the good news, the good news is healing is always happening.
Yeah.
You will heal.
A month ago. So no surgery.
Yeah.
My back is stable and I'm healing. But of course, my IC had been great, totally managed, totally under control. This happened. I put this brace on that ends at my pelvic bone.
Oh.
That I'm in 23 hours a day, and it's a girdle, it's a corset.
Oh.
And so of course I reached out to my urologist and said, I'm having a flare.
Yeah.
And so they gave me some more Urabel, which does help on I don't take it 4 times a day, like they say. I'm too sensitive to meds.
Right.
So
right.
I can maybe take it once every other day. And the aloe, I'm the one that did the Desert Harvest, and I'm taking all 3, the Curacin and the other one you taught, the C one.
Okay, chondroitin.
Yeah, so I'm taking all 3, and those help.
I would be doing something with PEA in it for pain relief. You got to calm the nerves. So I take, whenever I feel my nervous system acting up, where is it?
That one you showed, the aloe one?
No, Peora. Here, hold on. I think I put it in my bedroom. Hold on. Okay, that is so weird. It has a bowl.
Okay.
It's here somewhere. So
just go on your shop.
Yeah, it's right on the nervous system is getting amped up because I start getting, feels like pins being pricked in my skin randomly.
Yes.
Yeah, right. And it's just and it's like, it can be your leg, and then it can be your shoulder, and then it can be this, and then it can be that. That's a sign for me that my nervous system has definitely gotten a little bit more sensitive. And that's when I start taking the Peora. And I have to say, so it just started again, like 3 days. Oh, is that it? Here it is.
Okay.
Peora. So palmitoethanolamide, which is the active ingredient in this, in all the research studies has been found to be the most effective with neuropathic pain, like the pain that we have with central sensitization. And so I think this would be potentially interesting to try. I'm very happy with it because now I'm going through weeks of not having the pins, and then they slowly come back. And so then I do that again for a week or 2 weeks, and then it calms down, and then it slowly comes back again. But it's a relief rather than trying to fall asleep feeling like you're being stabbed by pins every 30 seconds.
Yeah.
Yeah.
It's just been frustrating with the two. So I have a wonderful urology department team that I see, and they're great through the years. The wonderful gyne I see through the years. They don't.
Yeah.
They do this, you know.
Right. Yeah.
They both agree. They both of them will agree to that I have IC. But beyond that, you know, I did have a hysterectomy at 38, so 10 years ago.
Mm-hmm.
So, yep, I have a lot of the postmenopausal dryness, all that going on too.
Right.
And so then they will come to me and the doctors will say, well, are you using your Premarin? No. Well, you're having a flare. You need to get back on your Premarin. That will help.
Yeah, but Premarin is like the junk food version of estrogen cream. Premarin is notorious for causing a lot of extra burning, even though it's so expensive. It is the least tolerated estrogen product. We do better with a compounded preservative-free estrogen cream. And so I
go to my psychiatrist with that. She does compounds.
Yeah, I get I use the Women's International Pharmacy for mine. Women's International Pharmacy, and their website is women'sinternational.com. Propylene glycol free. I've never had a problem with it. Whereas with Premarin, it burned a lot. The burning. When you start using estrogen cream, it's going to feel hot at first because but that improves over time. It improves as you use it. Your body produces more. It starts to produce mucus, and things improve. So it took about 10 days for the heat to go away for me. But with Premarin, when I used it, it always burned. It was always irritating. Always.
Because I kind of find I won't stay on it. I'll try it for a month or two and then back away for a few months again. And that might be why. It might be what you're saying. It's again with my drug sensitivities that I have anyways.
Yeah, but remember, you're using it topically. You're not taking it by mouth. And so because you're using it topically, you're not going to feel the systemic effects as much. And so you actually might be able to get away with it a little bit more. Okay. Yeah, but it's important. It's important. I mean, listen, I'm passive aggressive with my estrogen. I should have done it last night. I didn't. And I'm very that way with estrogen, and I should be doing it 3 times a week, and I don't. I might do it once, and then I'll do it 2 times a week. But it's that consistency is important. Definitely would benefit potentially from a little bit of estrogen.
Yeah.
Okay.
Yeah. So I just, like I said, I think with Evie and what you have been talking about so much, that the frustration with the 2 doctors bringing up IC. So now with a neurosurgeon who's dealing with the back, he's like, yeah, because I'm like, it's got to be interconnected. My IC was perfectly fine until I fell a month ago.
Well, but when you fell, you hurt your muscles.
Oh yeah.
Yeah.
Oh, yeah.
So
and fractured vertebrae.
Right. And so you're probably having a pelvic floor flare. You know, you're having
that's exactly what it would feel like. It's my pelvis. I wouldn't say it's my bladder.
Yeah. Yeah. So I just don't know when you can do pelvic floor physical therapy.
And I've never tried that. So. Wow.
Okay.
So that's like a new area, like for me to explore.
Yeah, definitely. Definitely. That's it. That's really, really important. So it's the chicken versus the egg. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? They're both involved. They cannot not both be involved. They are 2 interconnected, but one is driving the other. And so if we go back to when your symptoms began and try to recreate what was happening back then, you'd be amazed at the number of people whose symptoms began after a pelvic trauma.
Yeah. I mean, you know about the tailbone. Yeah. I slid downhill. Yeah.
Right.
Yeah, I hit
Right.
all that.
So, but see, we've known this since 2008.
Those are my finest moment.
Yeah. Yeah. But think
Yeah.
about this. We've known this since the big study was published in 2008 that muscles were heavily involved. And yet there are still doctors today, urologists today, who are not assessing muscle. They're just throwing patients on Elmeron, and we have to stop that. That's why this is a pelvic pain syndrome. We don't just want to stay in the bladder. We got to look beyond the bladder. So, well, listen, when do you get your,
Okay, it's been a month. Our hope is 2 more weeks.
Woo, yay. Okay.
Start to not have it on 23 hours a day.
Yeah.
Because it's really it's digging into my pelvis. It's not a fun thing.
No, I imagine when you're sitting, it's pushing right into your pubic bone.
Yeah. And laying in the recliner, which I'm supposed to do, and then walking, it's just horribly heavy. And I'm a whopping 5'2" on a good day. So it feels bigger than I am.
Oh no. Well, you've got 2 weeks to go. You are remarkably resilient. One of my favorite affirmations is let's see, you've never been more prepared to deal with whatever happens to you than you are at this very moment, because you are truly one day older and one day wiser and one day stronger. And you have gotten through this. 2 weeks, piece of cake. And you can always count on the fact that healing is always happening. That never turns off. So sometimes you just have to lay back a little bit and just let our body do our thing, right?
I've been laying a lot.
I know.
So back to the estrogen.
Yeah.
Do I need to get like a prescription from my doctor for that?
Yeah.
Okay.
Yeah, they need to look at your skin. They need to look at your skin, see where you are, and try to figure out how much you should do, whether you're doing it once a week, twice a week, 3 times a week, or whatever. So they have to look at your skin.
So just go back to them and say, I'm just not happy with the Premarin.
Right. Well, you just say it's too expensive. I mean,
it costs me nothing.
I know, but it does cost like $220 per prescription. Or just say that you'd like to try something else, that you love horses and you don't like the industry and you don't want to support the pregnant mare.
So again, what I should be trying to get?
Just say preservative, a compounded estradiol cream or a compounded hormone cream, depending upon what their preference is. But I love horses. I would never, I just like, sorry, I'm not giving money to that company that keeps horses pregnant and does that. So, all right. Well, keep in touch. Let us know how you're doing. And I can't wait to see you on camera without wearing that and hearing how much better you feel. You will do this. All right, hon. Nice talking with you. All right, Zoom. We're done with Zoom. Everybody be well. I'm going back to YouTube and Facebook. Okay? To everybody. All right. Zoom is done. So let's come back and check in with you guys. Okay, I look terrible. I'm just telling you right now, I look terrible, and it is what it is. It is what it is. Plus, we've got cloudy skies outside, smoky outside. All right. So let's wrap this up here. Let's do a last call. Last call for questions. Last call for questions. If I missed it earlier, please feel free to ask it again. Kathy says, oh my God, I get the stabs of nerves. I want to know more about Pure, the supplement, also estrogen cream. I also have vulvodynia. What is the site? Where do I buy it? Kathy, you can just go to icnetwork.org and go into our store, and that's where you can get Piora. So you got the pins and needles too, huh? Oh, drives me crazy. I started getting it 2 nights ago in bed, and I use a let me get what I use. Hold on. This stuff is the bomb for calming your skin down. CeraVe Itch Relief Moisturizing Cream. It's not an itch. I don't get an itch. I get a pinprick. But It's they did a clinical trial with people, and people experienced relief within 2 minutes. And I have to say, this stuff is amazing for people with skin sensitivity. So CeraVe itch relief. The CeraVe product line is just fantastic. It's so good. So I have the face cream, I've got the regular cream, and I have the itch relief. And I'm usually using it on my shoulders because you can see I have a lot of red spots on my shoulders, which is apparently going to be my future. Hi, Sherry. Nice to see you. Nando says, I would like to know if the meeting with the attorneys on August 13th was recorded. Why don't you go over to their website, elmeronlawsuits.org, elmeronlawsuits.org, and pop them an email. It was saved. It was recorded. I think the problem was they were concerned about confidentiality it was a kind of a loosey-goosey area. That's why they didn't quite put it directly on the website, but pop them an email. It's Kristen or Aaron are the attorneys, Aaron Dickerson and Kristen Basich, something like that. I think we have more than 20 lawsuits now. I think there are actually probably far more lawsuits now that have been filed against Elmeron since we've done that meeting. That was over a month ago. Ange says, started antibiotics on Friday and I'm getting pins and needles. I thought I was just a weirdo. Well, you could be having a side effect to the antibiotics. You certainly need to let your doctor know that that's happening. If you had the pins and needles before the antibiotics, then okay, it was something else. But if you're getting the pins and needles because of the antibiotics, that's not a good sign. That means that your nervous system is being affected in some way. And I would definitely call your doctor tomorrow and tell them, because I would probably be a little concerned about that. Let me check here on YouTube. Hello, YouTube. Hi, Nicole. Anxiety makes my IC worse. You betcha. Nicole says, I sat down with my chiropractor this week and asked to do x-rays, and let's look at my back and pelvis again, starting and from the beginning. Hello, Barbara. It's nice to see you. All righty. Anne says, how do you get to chat with Jill, and how often do I do these videos? I try to do them every Sunday, which means my day off is usually Monday. But we're in fire season here in California, and it's difficult. So last week it was 119 degrees. It's 111 here. It's 119 up in our store. And our power was turned off. We were on a flex alert, so we had to turn everything off. And so I could not do it last week. And then they turned our power off anyway. So it's always going to be a little dicey in the fall. I am known for dropping in and doing meetings during the middle of the week at odd times. Sometimes I do them in the morning. Sometimes I do them late at night because I'm trying to catch people in Australia, New Zealand, and in Asia. So make sure you like our Facebook page or go down over to our YouTube channel and like our YouTube channel, but also sign up for notifications so that when I go live, you will get an email. I want to do a lot more of these. I think this is the future. I love being a support group leader. I think that it's helpful to people. And if I could do this every day and just be a streamer, I would. But my time is precious right now. I get lots of emails. I'm editing a book right now. That's my big project. We got IC Awareness Month kicked off. We got our magazine out, answering phones for days. Now my big project this week is to finish up this new book on IC. And we're prepping it for Kindle. And so that's what I'm going to be doing for the next 2 weeks. And hopefully we'll be done. All right. I Tara says, anybody tried marshmallow root? Marshmallow root, we even have a marshmallow root tea that I just bought for our store. Understand that marshmallow root does bother about some of the people who try it. It's about a 50-50, but for some people it can be a little bit soothing. A better one is chamomile herbal tea or peppermint herbal tea. And by the way, I'm bringing in throat coat tea, and I'm bringing in another tea for cold and flu season when I see patients have trouble when we get colds or flus, God forbid COVID. So I'm bringing in a couple of teas from traditional medicinals that I see patients swore by in our cold and flu survey last year to give you a few more things. Bobby says, what about chemical burns in the bladder? Chemicals burn the bladder all the time. That's the number one cause of bladder injury is a chemical exposure, whether it is chemotherapy or drinking too much diet soda or being exposed to a medicine or a chemical that is damaging to the tissue like ketamine, or there's some antibiotics that are brutal on the bladder, like Augmentin is really aggressive and irritating to the bladder. So chemical burns happen. That's a chemical injury. That's not a disease process. Your job is to create an environment that will support bladder healing. So you've got to follow the diet. Don't pour acid on the wound. You've got to follow the diet for a good 3 months, maybe 6 months. Give your bladder plenty of time to heal without irritating it more with other chemicals. Sherry says, I had endo in my 20s, had a hysterectomy with dissecting the endo away from my ureters outside of my bladder and bowels. I'm wondering if I still have symptoms and scar tissue that's on my bladder. Maybe, possible. Eulalie says, is it possible to reverse sensitized nerves like pudendal nerve or nerves in the perineum? The answer is yes. With pudendal nerve entrapment, which is the number one cause of like persistent genital arousal disorder or vulvodynia or sciatica, we have to try to figure out where the nerve is compromised in the first place. Is it being constricted or pressed on by a Tarlov cyst, as an example, up at the spinal cord, off of the sacrum? Or is there a tight muscle or a bony structure that might be pushing on that nerve? So goal number one is to try to figure out what's tripping out that nerve in the first place. And then number two, it's about doing things that calm and soothe nerves. And so there are some medications like gabapentin or Neurontin, amitriptyline, or, I think the one that's the most exciting right now is to have an over-the-counter palmitoethanolamide. Lots of research done with PEA on a variety of conditions like fibromyalgia and sciatica and burning mouth syndrome and IC. And in those studies, what they collectively see is that it seems to work the best on nerve-driven pain. And so I think Peora would be a very, very interesting experiment for people who have maybe some pudendal nerve stuff. But of course, you've got to work with your doctor. They've got to do a nerve block, try to figure out which nerve is the issue, et cetera, et cetera. Eulalie, so I just got your question, Eulalie. Nerdin says, I have Hunter's ulcers, went to my doctor because my flares were out of control. I prescribed Urabel, saw a huge relief, taking it for a couple of days. We also decided to do a steroid injection next week because I'm going out of country and didn't want to deal with any flares. My question, do you know of any side effects with the steroid injections and a long usage, even though it's only... No, honestly, I don't. I personally don't. The advantage of steroid injections directly into the bladder wall is that it doesn't leave scar tissue like fulguration would or laser therapy would. But yes, if you do use steroids for long periods of time, there is a potential for some side effects, and that would be a great question for your doctor. I would have to look at the research. I just don't know. Sherry says, is there delay in shipping from the ICN by the fire? No, because we can work right now. We couldn't work last week, but we are working today. And even if you got it on Amazon, you would be getting it from us anyway. So yeah, you can order from us. We should be shipping tomorrow. Knock on wood, my friends. Ange says, has anybody gotten COVID and had flare from it? Yes, 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 yes. Ange, we are doing a survey research study on that right now. Right now, I think the last time I looked, we had 26, 27 patients with COVID and IC. In fact, let's just go over there. Let me just go pull the data and let's see what we are learning from patients, IC patients who have had COVID. So hold on 1 second. And I'm sorry that that happened to you. Let us see, let us see, let us see. I also have a canker sore at the top of my mouth right now. It's like, okay, I've got 33 patients who have completed our survey on COVID and IC. And let's look at the results here really quickly. So I've got, okay, so these are all patients. About half of them were actually tested positive for COVID. Others could not get tested, but their doctor thought it was COVID, et cetera. So did COVID change your IC symptoms? 73% say yes. Did the pain get worse? Yes. Yeah, 27% said their pain increased severely, 33% moderately, 21% said slightly. Did the frequency get worse? The answer is yes again. And then there's a whole question on were there any other IC symptoms? Did you require hospitalization? 6 IC patients were hospitalized, 27 were not. So that's the basics from our survey. So Radha says, I had steroid injections once for my ulcers and they are all gone, no side effects. Radha, yeah, baby, that's what we like to hear. We love success stories. We love it. Understand here that if you'd gone to some groups on Facebook, they would have told you that you have got to take antibiotics, which is not true. You are living proof that ulcers can be treated with steroids and the ulcers go away. Maura says, Jill, you're amazing. I watch for my daughter. Aw, thank you. All right, my friends. Well, listen, I'm about tapped out. It's been a long week. I've worked every day, including yesterday all day. And now I've worked today for most of the day. So I think I need to give my voice a rest. So I'm going to give you your homework. Here's your homework. Number 1, if you found this helpful, please, please think about becoming a member of the IC network so you can get the magazine I am so proud of, our IC Optimist. This is now, we've been doing this for 18 years. And you know, we just learned so much. We just have to do it. So there are 3 different memberships, $25, $50, $100. You can go over to that website, check it out. If you don't want to become a member, please think about making a donation because ultimately I do have bills to pay and a little donation, even $5 would be very much appreciated. If you're on Facebook, you can give me whatever the little Facebook currencies are there too. You can sign up for our free newsletter. I send out about 1 newsletter a month. Don't sell it to anybody. I really respect your privacy. And so here's your homework. For 15 minutes a day, I need you to do something to nurture your spirit and your soul, whatever that is, whether it is walking among a redwood or going to church or listening to a lecture or reading your Bible or whatever faith book it would be. Do something every day to comfort you. We need comfort right now. Number 2, I need you to do something for your bladder or your physical or your pelvis. Please, please make a good decision and protect your bladder, etc. I need you to do 15 minutes for your brain. You know, you've done it today. You've watched my lecture. You know, these lectures are pretty aggressive and educational. But tomorrow you need to read something too. So get on over to our website and read a blog. For 15 minutes a day, I need you to laugh because your brain modulates pain in the presence of laughter. Laughter is good. If pain is accompanied by tears, your brain will worsen it. If pain is accompanied by laughter, your brain will lighten it. So laughter is everything. So please do something that makes, like, play Among Us. I want to get an IC group of people to play Among Us and play some games together. I love playing games. If you'd like to do that, pop me an email. And last but not least, you notice that we did not mention politics at all during this meeting. I'm going to tell you right now that IC patients cannot stand for hours to vote. You cannot do that. You need restroom access. So please ask for an absentee ballot or go vote early. Your voice matters, but your vote matters desperately this year. Desperately this year. We have a new statement from Social Security that if Donald Trump's payroll tax is passed, Social Security disability will end next year. They will run out of money. And then in 2023, retirement benefits will end. They will run out of money if Donald Trump has his way. So please, please, please vote blue. We have got to save our disability benefits. We have got to save our pre-existing condition health coverage. And we need sanity. I cannot wait for the day where I don't have to read conflict and listen to that person who drives me crazy. I want to be able to walk by my TV and not do this, which I do if I hear a certain person talking. You know who I'm talking about. The anger is real. Okay, so please register to vote and get your family members and friends to vote too. Okay? All right, my friends, I'm going to let you go. Have a good one. Sorry for being political, but we have to be until the election. So at least I did it at the end of the meeting. Okay, see you later. Goodbye, Facebook. All right, YouTube. All right, my YouTube friends. I wish you well. Last call for questions. Last call for questions on YouTube. All right. I will see you guys later. You know where to get a hold of me if you need me. I'll see ya.